Hey everybody. Welcome to Rounds. We'll wait just a few more minutes, just so then more people can join. But yeah, so like 8:43, we'll get going.
Hey, Jake, good morning.
Yeah, man.
Do you think I can share my screen?
Absolutely. Just give me 2 seconds. Go for it.
Thanks.
You're a popular guy, Ahmed. Like 30 people just joined the room just to see your presentation. So
Can I see the chat while I'm presenting? Because
I think there is a way. I'm forgetting. I haven't made use of the chat. Just like hover your mouse around your screen, and then I think there's a way, like, I think when you're sharing your screen and there's like a green stripe at the top that says you're sharing your screen, I think you'll be able to see a bunch of icons pop up, and then I think you can press like chat or something like that, and you can see what people are saying.
yes. And can you see that I can see the chat? Like for now, you can see my screen, not the chat, right?
Yeah, I can see your screen, but not the chat. Yep.
Okay.
So I'll say 1 more minute, and then yeah, I think you'll be good to go. Okay, I think we're good to go. So whenever you're ready.
Let's start. So hi, good morning, everyone. My name is Ahmed Ishmaeli. I'm one of the R5. Today, I will present to you back pain as one of the cardinal topics. So, okay. So we will start with a short introduction. Then we will have 6 cases before ending. So let's start. We know that back pain is one of the most common presentation to the emergency department. This study was done in 2018 in 4 emergency departments in Canada, and it showed that the total back pain presentation was about 3.1%. From those, 60% from those back pain presentation were due to mechanical cause, and 10% were secondary to another cause. So imagine that you have 10 patients with a back pain. One of them will present to you with a secondary cause, not a mechanical back pain. Now, once you get into the room, you need to know your red flags in your history and physical exam to help you in your next step. So the most important thing that you should elicit in your history, if there was any history of, I use a mnemonic that I like, which is called tuna fish. I'm not sure if you're familiar with it, but basically if you will have for the T, if there is any history of a trauma, For the U, if there is any unexplained weight loss, if there is, for the N, if there is any neurological symptoms in case of your history or your physical exam. So for example, any loss of motor, any loss of sensory, any saddle anesthesia, any urinary incontinent or retention. For the A, it's mainly for the age, if it was more than 50. For the F, if there is any history of fever. For the I, if there is any history of IV drug abuse. For the S, if there is any history of steroid. And for the H, if there is any history of cancer. So this box is from Rosen for the red flags in your history and physical exam. You should know it before going in to see your patient, and you make sure that you asked those questions and do that physical exam. Now, after going out of the room, you should have a specific differential in your mind. In Rosen, they divide them into spinal causes and extraspinal causes. So if we said spinal causes, it could be from quada equina, if there is any spinal epidural abscesses or hematoma, if there is any fracture or any infectious discitis, for example. Now, for the extraspinal causes, think about the abdomen if there is any aortic aneurysm. Think about the chest if there is any aortic dissection. Now, usually with the aortic dissection, it will give you a thoracic back pain more than a lower back pain. But in some cases, it might present with only back pain. You should also think about your GU, if there is any renal colic or pyelonephritis giving you that back pain, and if there is any musculoskeletal cause of the pain. And you should always expose the patient while you're examining the patient, so you will not miss a zooster. Now, there is a specific approach in Rosen. I didn't like it much, but this will guide you in terms of your investigation that you will do. So let's say that you did your history and physical with the red flags, and you elicit that there is a cancer risk in your patient, for example. You will divide them into lower suspicion and a high suspicion. If you think that your suspicion for a cancer risk is very low, you might do a plain X-ray with the ESR and CRP. If it's normal, that's it. But if it's abnormal, you will do as you will do with your high-risk patient, and you will advise for an MRI. Now, if you think that there is an infectious risk, the same thing, you will divide them into low or high. If you have a high suspicion for infectious infection, for example, this patient is an IV drug abuse, has a fever, you should do an MRI. But if your suspicion is very low, you can do ESR and CRP. If it's low, that's it. But if it's abnormal, you should go ahead with your MRI. Now, if you think your back pain is associated with more chest and abdominal or flank symptoms, you should go with your exam. For example, if you're thinking this is more a AAA, you will do your ultrasound. If you're thinking this is more a renal colic, maybe you will go and do a CT scan. Now, if you have a risk for a fracture, for example, an old age using steroid, osteoporosis, then you will do your plain films to make sure there is no fracture. And if you have a progressive neurological symptoms and you're thinking more quada equina, you should do an MRI and do an emergent consult. If there is no red flag and you think this is more a mechanical lower back pain, or a sciatica, you should treat without further investigation. Now, your indication to do imaging is basically based on also your red flag that we discussed before. For example, if you're thinking there is a history of malignancy and there might be a spinal metastasis, this is an indication to do an advanced imaging like a CT or an MRI. The same thing if you're thinking there is a fever with localized back pain and you're thinking a spinal epidural abscess, you should do the same thing. with advanced imaging. Also, if there is a history of IV drug abuse and you're thinking it could be an abscess or vertebral osteomyelitis. If there is any new neurological deficits and you're thinking quadra equina, the same thing. Direct trauma, and you can't see that in your plain film. If there is any worsening pain after a spinal surgery, it could be also a spinal epidural abscess. If there is a sudden onset with a back pain and patient is on anticoagulant, you should think about spinal epidural hematoma. And the same thing if there is any spinal epidural procedure that was done recently to that patient. All of those are indication to do an advanced imaging. Now, once you decide to do your advanced imaging, there is another algorithm in Rosen, which will help you in terms of the treatment more than the investigation. And in this one, they will start initially with NSAID, muscle relaxants, and in some cases you will consider opioid and steroid, and then they divided them into three categories. The first one, if there is any neurological deficit or the post-void residual was abnormal, they will divide them into febrile or afebrile. In case of afebrile, thinking about quadra equina, tumor, hematoma, and fracture, you will start your steroid to relieve the cord compression, and you will ask for an MRI. If it's a febrile, you will start your broad antibiotics, and then you will do an MRI to confirm the diagnosis. Now, for box number 3, if they will divide them, they said if it's like there is no neurological deficits or it's only sensory, you should do one, a plain X-ray if you're thinking there is a risk of fracture, and 2, if it's like only sciatica and muscle strain, you will continue with the NSAID and follow up. Now, to make that more clear, we will do 6 cases. Feel free to shout out the first differential that come to your mind, or type it on the chat. That it will be mainly the differential that you think it's the most serious thing that I want to rule out in that case. So let's start. Case number 1, you have a 38 male. Oh, I don't know how to get rid of the videos. Okay. So this is a 38 male presented with acute lower back pain that started immediately after he moved the furniture. His pain is radiating both down legs, and he feels like he's tripping. His exam vitals were stable. There was a mild midline tenderness with paraspinal at the left, at the lumbar and sacrum area tenderness, with bilateral loss of strength in distal lower extremity. He has numbness and in his bilateral feet, and reflexes were +3 both in knee and ankle. So what is the first differential that comes to your mind that, oh, I think I need to rule out this cause of back pain in this patient?
Quadra equina.
Excellent. So in this case, we need to make sure that this patient doesn't have a conus medullaris or a quadra equina syndrome. The causes of quadra equina is basically a massive central disc herniation, which is the most common cause. If there is any spinal epidural abscesses that causing the quadra equina, hematoma, trauma, or malignancy. The symptoms for those patients, mainly they will present with back pain that radiate to both legs with sensory or motor deficits, saddle anesthesia, bowel incontinence, and urinary retention. The sensitivity of urinary retention is 90%, and the negative predictive value, if it's absent, is a 99% for quadra equina. And if there was any decrease in ankle reflexes. Now, some of those patients will have also urinary incontinence. It's basically after the retention, it will be overflow incontinent. So make sure also to elicit that symptom. The difference between quada equina and conus medullaris, in conus medullaris, it would usually present as an abrupt more than quada equina, which will be more gradual. And it will usually in quada equina will be more unilateral. The incontinent will be more early in conus medullaris, and the sensory loss will be asymmetrical in the in the quada equina syndrome with the saddle anesthesia. The reflexes, as you notice, that patient has +3. That should make you think more about conus medullaris more than quada equina, which will present as a hyporeflexia. For the management, you should do your post-void residual. If it was less than 200, that means it's normal. You should do an MRI. Usually they will do a surgical decompression, so you should consult your colleague from spine. Steroid can be given if you think that the cause of the quada equina is malignancy more than anything else. Now we will move to case number 2. This patient is a 34 male who's known for IV drug abuse, presented with acute onset low back pain, which radiate to both legs, has no weakness or numbness. On his exam, BP was 112/70, heart rate 92, temperature 38, satting well in room air, has a mild midline tenderness at L3, and his neuro exam is unremarkable. What's the differential that comes to your mind that you want to rule out in this patient?
So we have discitis and epidural abscess.
Excellent. So discitis or spinal epidural abscess and vertebral osteomyelitis, you should entertain that diagnosis once you see that this patient is having a back pain and a fever. So you should suspect spinal epidural abscesses in patient with back pain, neurological deficits, and fever. And this triad only present in 15% of your patients. Also, if this patient is an immunocompromised patient or he had a recent spinal procedure. The risk factor that may make you think about, sorry, the risk factor that make you think about, sorry again. So the risk factors that makes you think about this diagnosis is basically IV drug abuse, if patient is immunocompromised, if this patient is an elderly, history of alcohol, or if this patient has a recent bacterial infection or indwelling catheter. The most common organism that causes spinal epidural abscess is Staph aureus. But in IV drug abuse, you should think about Pseudomonas, and other causes can be streptococcal or any negative bacilli. The investigation for the CRP and ESR, you will use it, but not in a high index suspicion. If you have a very low suspicion, you will use it. If it's negative, will help you. But in a high suspicious cases, you should skip the CRP ASR and go right away to MRI. Doing CT won't really help you. If you will see it in CT, that's good, but it cannot rule out spinal epidural abscess. So think about that in your next case that you suspect a spinal epidural abscess. You should start them on ceftriaxone and Vanco and ask for a surgical consult for a possible debridement and laminectomy. Now we will move to case number 3. This is a 60 male non-prostate CA who presented with a low back pain for the last 4 weeks. His pain is radiating both legs with a burning sensation on feet. His exam, he has a stable vitals with mild midline tenderness at the lumbar and sacrum area, and his neuro exam is intact.
Cancer.
What exactly in the cancer you're thinking about?
It's a mix from the prostate cancer.
Excellent. So in this case, you should entertain the diagnosis of spinal metastasis. The reason that those patients in danger because they might have a cord compression and they will present more with neurological symptoms. Now, you notice that this patient pain was only for 4 weeks. I just want to make sure that you know that the definition of acute low back pain, if it was less than 6 weeks, which is a bit longer period than at least what I expected for a back pain. The tumor that associated with bone mets, prostate, testes, breast, lungs, and kidney. So with those history of cancer on those area, you should, and patient has a back pain, think about spinal metastasis. The risk factor to develop spinal or bone malignancy, if the pain was more than 1 month, history of cancer, unexplained weight, increased age, and if the patient pain was persistent. For the management, doing an X-ray can help you to see if there is any compression fracture or a lytic lesion, ESR, CRP, and calcium if the history is consistent with hypercalcemia. DEX can help you if the patient has neurological symptoms with cord compression and to relieve the cord compression. Using calcitonin and bisphosphonates if the patient has hypercalcemia. Now doing MRI, if there is a hard neurological finding, it should be done within 24 hours. But if it's only the X-ray that's consistent with it, you can do the MRI within 7 days, and you should have also an oncology consult, which I'm sure that the patient is followed by oncology. Now, case number 4. This is a 73 male who's known for coronary artery disease, has AFib and on warfarin, presented with acute back pain and leg weakness. His exam is stable, lumbar tenderness, bilateral loss of motor in the distal lower extremities. So what should be the differential that you should entertain in this case?
Aortic dissection.
Okay. What else? I'm trying to see the chat. If there was anything in the chat, I couldn't open it.
With the hematoma is mentioned.
With what?
A hematoma is mentioned as well.
Yes. So a hematoma, given that this patient is having, this patient is on anticoagulant. So for spinal epidural hematoma, there is 3 types. If it's traumatic, you will think more about spine in a spine fracture. If it's a spontaneous, for example, in this case, the patient is on anticoagulant and presented with an acute back pain. If there is any history of coagulopathy, thrombocytopenia, vascular malformation, also it can present as iatrogenic from epidural anesthesia. The diagnosis is made by an MRI. You can use CT if the MRI is not available, but it's not enough to rule it out. And you should image the whole spine. The hematoma may extend. For the management, it will need an immediate consultation with the spine and with the surgery for a possible decompression. You should consider also to reverse the anticoagulant. If it's only a mild symptoms, you can manage it conservatively, but it should be with a consult with the spine surgery, and you can give DEX. Now, we will move to case number 5. This is a 59 male who's known for hypertension, presented with acute low back pain, followed by an episode of syncope. Now, his pain is radiating both legs. His exam is stable with mild lumbar tenderness, and his neuro exam is unremarkable. What do you think?
This one, aortic dissection.
Good. So the history of the syncope and hypertension, you will ask for sure if you think that this is it's not more an aortic dissection, it's more the AAA that you should think about. because as I said, with the aortic dissection, you will think more with a thoracic back pain more than a lower back pain. If you will do an ultrasound at the bedside, you will have your diagnosis. So for a AAA, you need an IV access, blood product as needed with a vascular consult. And as I said, with aortic dissection, it's more a common cause for a thoracic back pain more than a lower back pain, but it might present also as a lower back pain. Now we'll move to case number 6. This is a 39 female who was previously healthy, presented with acute onset low back pain, started immediately after she moved furniture. Her pain is radiating to the right leg. Her exam, stable vital, mild midline and bilateral paraspinal lumbar sacral tenderness. SLR test was positive and her neuro exam is normal. This is the most common presentation that I would say that we'll see on a back pain.
Sciatica.
Excellent. So this is a radicular pain or a non-specific lumbosacral strain. For this presentation, it's a diagnosis of exclusion that it showed that you thought about the other differential and you excluded them from your history and physical and red flags. There was a study that was published in 2018 to see how sensitive and specific your red flags in excluding other causes and saying this is more a non-specific strain or sciatica. And it showed if it's positive and it's there, it will make you more suspicious of secondary factor. But the absence of red flags doesn't mean that there is no red flags. So be cautious when you're using your red flags in your next case of back pain. The finding that it might suggest a functional back pain, positive SLR test, superficial tenderness, non-dermatomal sensory loss, or pain on axial loading of the scalp. For the SLR test, basically, if you will raise the affected limb, you will have a pain past the knee at 30 to 70 degree. And for the cross SLR test, you will extend the asymptomatic leg and you will have the pain radiating down to the affected leg. The sensitivity is higher in the SLR test, but the cross SLR is more specific. For the management, you can use your NSAID, Tylenol, muscle relaxant, stretching, physical therapy, heat. The American College of Physicians stated that Tylenol is not effective in treating mechanical back pain. So I would say go with NSAIDs and more than the Tylenol for that back pain. Using gabapentin or Lyrica is good for patients with neuropathic pain. If the patient has more severe pain, he might need opioid or admission. And I would say if you have your ultrasound and you know how to do a nerve block, that will help you not to prescribe opioid and do an admission for those patients who had a severe back pain. The most important thing is to do education and reassurance. Those patients doesn't need a prolonged bed rest. 90% of them, they will improve over 4 to 6 weeks. Give them a good return precaution and red flags when to come back to the emergency. And for those patients with the sciatica pain and radiculopathy pain, they will need a follow-up with their primary doctor and they will assess for a non-emergent MRI. Now we reached to our conclusion. I would say the causes of back pain that you cannot miss: conus medullaris or quad equina, spinal epidural abscess or vertebral osteomyelitis, spinal metastasis, spinal epidural hematoma, AAA or aortic dissection, spinal fracture with a cord compression, or if there is unstable fracture. And we discussed those diagnoses throughout the presentation. Thank you so much. And if you have any question, please feel free.
All right, awesome. Thanks, Ahmed. That was great. Great summary, great cases. Okay, so moving on. So we're excited to have Dr. Josh Wang here. Dr. Wang has pretty regular Tox rounds that can be difficult for some of us to get to. So we're really excited that he's going to be giving us just a presentation on some of his favorite hitters here. So go ahead, Josh.
All right, you guys see me? You hear me?
Yeah.
Oops. Great, so it's
Yeah,
good to be with all of you today. Today we're just going to be reviewing some of the kind of quote-unquote updates in toxicology, or maybe some new topics that shine a different perspective on pathologies that we encounter not infrequently. Okay. It's going to be case-based, kind of like the previous presentation, and I welcome questions at any time. Okay, so just unmic yourself or raise your hand, and perhaps Jake can chime you in. Okay, so we're going to start off in familiar territory. Imagine yourself at the Montreal General, perhaps. So we have a 62-year-old man who crashes his car after drinking. He's cleared by the trauma team, and he's got one foot out the door, but then he tells you that he realizes he has a problem with alcohol, that he's been wanting to quit for a long time, but he's worried about possible withdrawal symptoms. It's the weekend, there's no inpatient beds available. Medicine's going to be very, very reluctant to admit this guy, since they probably wouldn't want him on the floor anyways, due to, again, a risk of withdrawal. I just want you guys to think for yourself for a minute. How would you manage this patient with medications? I know sometimes we tell patients to gradually taper off their drinking. I've used that approach on more than one occasion, but it does come across as somewhat counterintuitive to the patient. It seems as maybe not too compassionate. And also certain patients, they're not exactly able to titrate their alcohol intake just to symptoms. They have impulse control problems, right? So that one drink quickly turns into 10 drinks, and the ability to fine tune that medically is not really, within their capacity, despite their best efforts. So think about this problem. How would you give this patient medications that might help their condition? Would anybody use benzodiazepines?
I don't think so, because that could also lead to impulsive behavior with those medications. I don't think I would.
Perhaps, right? Yeah. So the point you illustrated, Jake, is one that many people think of as well. So what happens if the patient goes overboard on benzodiazepines, despite their assurances to you that they're going to adhere to the taper that you prescribe them, despite their assurances that they're not going to combine it with concurrent alcohol use. There's no way you can guarantee that, right? But there's a lot of things that aren't guaranteed in life. And, in my personal practice, I'm becoming more permissive with these, prescriptions, just because I feel like it's still easier to taper, medications to symptom control as opposed to, Labatt 50s. And it medicalizes the issue, which sometimes is good, but sometimes can also be bad. The reason I'm bringing this up in this particular context is that there's another treatment that may or may not be familiar to you, which is gabapentin. Okay, this is a really jack of all trades drug. Okay, it doesn't have anything to do with GABA, despite the name, despite the intent of the original drug hunters that created it and validated it. It acts on voltage-gated calcium channels that are neuron specific, although it does spill over to other calcium channels when taken in overdose. What it does is it's been found to decrease the cravings as well as decrease the symptoms associated with alcohol dependence and alcohol use and alcohol withdrawal in an outpatient setting. Okay, so note a couple stipulations I've made there: in an outpatient setting. All right, what that implies or what that means is that these are patients who are not in active, moderate to severe alcohol withdrawal, where there's a plausible chance that they'll only have mild to moderate symptoms, and people who are capable of maybe seeking medical care if things kind of go off the rails, right? So let me show you a couple of data points just to bolster that point. So I said it's updates, right? But this study's from 2009. That said, if you never heard about that, it's an update for you. It's also an update for me. I found about it well after the time of publication, okay? So I couldn't really nitpick it at Journal Club per se. So this was a randomized control study of lorazepam, which is, a typical, benzodiazepine substitute for alcohol use in this setting, compared to gabapentin at 2 doses, 900 and 1200. They originally had a 600 milligram a day control arm, treatment arm, but patients were too symptomatic on it. So they erased that category quite quickly. So at relatively high doses of gabapentin, they looked at, amongst the things they looked at were 2 primary indicators of kind of withdrawal severity, as well as, its effect in curbing alcohol use and alcohol cravings. So in terms of withdrawal severity, we have the left-sided figure, which uses a score that we're familiar with, right? The CWA-AR, so an abbreviated version of the CWA, which we use as a part of our ED protocols at the NUHC. And we see that, after initiation of all treatment groups, gabapentin and lorazepam, the alcohol withdrawal severity decreased. Now, there's no placebo. You could play, a medical skeptic and say, well, how do you know this is not due to placebo effect? You can't, right? But I don't think it'd really be ethical to necessarily randomize patients to placebo, especially, with the hindsight that 600 milligrams a day caused intractable withdrawal symptoms that led to collapse of the group. So lorazepam, the dose they used were no homeopathic doses either. Is 2 milligrams PO TID, quite high. So these are, patients at risk of moderate alcohol withdrawal, I'd say. So let's put a pin in that, at least in this randomized control study that was taken in outpatient, recruited through a newspaper ad. Gabapentin seemed equivalent at high doses to a high dose of lorazepam orally. Just looking at the other outcome of interest, right? These patients are interested in quitting alcohol and curbing their urges, right? So how does this actually work? Well, we can't install 24-hour home monitors. That'd be disturbing to all of these patients. So we rely on self-reported outcomes. And according to self-reported outcomes, patients had fewer cravings and less probability of drinking in the gabapentin group on some occasions, okay? Doesn't rise to the level of statistical significance, but compared to a relatively reasonable, let's say gold standard of a medication substitute for alcohol, gabapentin performed pretty well in 2009. Any questions so far? All right. So this was followed up with another
Josh,
RCT from a different group in a different population with a slightly higher risk of alcohol.
Sorry, Josh. One sec, Josh. There's a question from Becca.
Yeah, shoot.
I just wanted to know how, if they said in the study how long they gave this prescription for. You might have said it and I missed it.
Yeah, no, great question. So I'll just stipulate that everything I'm covering here is more of, presented as a curiosity. I'm leaving it up to you guys to kind of do the details if you intend on prescribing these to your patients. But from what I know about this paper, again, this is not a practice I do all the time, right? But the initial dose outlined here is the starting dose. I think the authors prescribed it to patients for 3 days. It's a distributed TID, and then there's a rapid fixed taper with the goal of stopping all the medications at around, I want to say like 1 to 2 weeks, okay? But again, this is more to illustrate the concept that gabapentin can be used to safely curb urges, as well as curb the symptoms of withdrawal in certain populations, right? Not for everybody. Again, I want to emphasize this is not for patients in the ED already symptomatic to a mild to moderate degree, who you think they're going to get worse, right? But it's for those patients ideally with outpatient follow-up available either through their GP or a collaborative internal medicine clinic or a substance abuse clinic. But this particular study looked at a rapid taper of gabapentin and lorazepam. Is that okay, Becca?
That's awesome. Thanks.
Of course. So a similar study, right? 1800, 900, but this time they include a placebo arm. They took away the lorazepam control, okay? And these are patients, again, recruited from an outpatient setting, but also being enrolled in a pretty intensive kind of outpatient therapy program with close medical follow-up. It goes without saying that patients who are enrolled in RCTs, are subjected to a selection pressure, whereas, patients who come to the ED perhaps not of their own volition, i.e. after a car crash, might not have the same social supports or motivation despite their initial interest with their 1 foot out the door, okay? It's not to say there's no overlap at all, but we have to consider these differences when we apply the literature. So again, these authors found good treatment effect in terms of reducing the number of days of abstinence and, well, increasing the days of abstinence and increasing the days of heavy drinking averted in gabapentin versus placebo. They didn't report the adverse effects in such a granular fashion, okay? But if you just take their word for it, which I'm inclined to do, they report no significant, serious adverse effects, vis-a-vis delirium tremens, severe, convulsions, hospital admissions, things like that. The actual data, when you drill down to it, it's like, a little messy, right? But they did some statistical probing and they found some signs of whatever a linear dose effect is. I'm not a math guy, okay? They found evidence of a progressive increase in effect size as the dose of gabapentin increased in their study group, okay? And you can see here a clear distinction between the previous group and this group, right? Thank you, Becca, for the prompt earlier. These patients were treated long-term, right? 1, 2, 3, 4, 12 weeks, right? And followed up this entire time through therapy, through medical monitoring, right? Which is oftentimes more than we can offer from the ED. I would hate for you guys to take away, the idea that just dispensing a couple pills of high dose of gabapentin is going to substitute for, all of the ancillary supports that these patients get over the course of the study. But it's something. It's not nothing, right? Ideally, you can hook this patient up with their own family doctor or a substance abuse clinic, but that's not always possible, especially on a weekend evening. Does that sound good? Questions?
I just have a quick question, Josh. I guess perhaps what's not clear to me from these two studies is whether gabapentin is actually better than lorazepam. I mean, what are we gaining? Yeah,
so good question. Lorazepam, just theoretically, right? The risk of combined sedative hypnotic toxicity when taken in conjunction with alcohol is much higher. It's not to say gabapentin is without any. We know that in overdose gabapentin, in isolation can cause sedation, and it's exacerbated by alcohol, but the effect is, in terms of magnitude, is far less than that of, let's say, lorazepam combined with combined with alcohol.
Okay.
Now, there's no RCTs of this, but you ask any toxicologist where they're exposed to a large patient population that filters down to severe cases. Gabapentin toxicity rarely even rises to the attention of the toxicologist because they're handled by nursing-driven protocols for the majority of the time. I think in terms of non-inferiority or superiority, you can quibble, I think, about the effect size and whether or not the previous study, which is admittedly small, is powered enough to detect significant differences. But these patients are inherently difficult to kind of study, even within this self-recruited population, right? It's not like we could get ends of 100, ends of 1,000, and these are ultimately now generic medications without the industry interest to drive up a new indication, especially when people can prescribe these off-label. Does that hopefully answer a bit of your question?
Yes, yeah, that makes sense.
Okay, all right, thanks. So next case. So we have a patient on methadone maintenance therapy, right?
One question regarding the there is a misuse of gabapentin cause and an addiction and a withdrawal also symptoms?
Is misuse associated with withdrawal?
Could the gabapentin cause addiction and also withdrawal?
Yeah, so the answer is yes, but with a big asterisk, okay? Gabapentin misuse and abuse is reported in the US, right? But I think it's important that we weight kind of the effect size and not just a binary yes, no, can it happen? The likelihood of a patient having gabapentin dependence and abuse is far less than a patient who's already known to have alcohol abuse and asked to start drinking again. Or let's say a patient known for alcohol abuse and given a prescription for, let's say, a high number of benzodiazepines in their pocket, right? I think the proportionality there is not equivalent. So gabapentin might have a favorable safety effect profile, but this is just an opinion. I'm exposing you to something new here. It's all up for debate, and I just want you to be aware about this kind of pharmacological option. Okay, I'm not advocating for it.
Thank you.
Okay.
There's a question, hand raised from Dr. Ken Doyle.
Yeah.
Yeah,
And,
Josh, I don't know if you saw the Cape Wednesday night grand rounds over the last, I guess, year or so ago, where they were saying what they do at this hospital in Toronto is they load them up with up to 20 milligrams IV Q1H of Valium until their CWA is less than 2. Then they're discharged without symptoms. They do not go home on benzos. They chose Valium because of its volume of distribution. And that would be slowly coming out of the fat and back into the blood over the next few days. And for the motivated patients to decrease their craving, as long as they had follow-up, they put them on Wellbutrin or some other medication, I forget, if they had liver disease. And that was their protocol.
okay. I love that plan, right? So Valium, I'll do you one better. I like it better with chlordiazepam epoxide, which is the oldest, dirty granddaddy of, that sounds gross, but like a benzodiazepine, right? With so many active bioactive metabolites that a single dose lasts until like next Wednesday, right? So, this auto tapering effect of diazepam and chlordiazepam epoxide is very, very, very nice, right? In the setting of alcohol withdrawal that's already symptomatic in the ED. It takes away the impulse control issue, right? IV loading, sure. I mean, ideally, I would like to have the patients tolerate PO loads before they're gone, right? But IV loading, if that's their protocol and they have a safety record, at least in their own center, why not? I guess it's like easier. No, there's a lot to be said about that. And this recreates a lot of the, the tenets of a symptom triggered therapy, which is an update in toxicology. If you look back to the 80s, I guess, where frequent reevaluations, I'm talking like Q30 minutes, Q1 hour, and frequent titration of oral benzodiazepines. So in the study, they used the chlordiazepam epoxide, but you can substitute with Valium in Canada because we don't really have chlordiazepam epoxide or Librium. This would be the best way to attack the patient's symptoms early and to reduce overall benzodiazepine use because you front load it and you let the patient auto taper. So that's my opinion about that. I'm not familiar with using bupropion, but it sounds interesting, counterintuitive. I'm going to do some more reading about that. Thanks, Ken. All right. So we got an opioid withdrawal question here. Okay. So we got a 32-year-old man on methadone maintenance presents with what sounds like precipitated withdrawal after taking an unknown pill, vomiting, diaphoresis, myalgias, right? Goose skin. What medications would you give this patient? Think about it. Right. So some people would think about buprenorphine and naloxone. It's gotten a ton of play recently, right? A lot of things that are good about it, right? It's ultra potent, long-lasting, partial mu opioid agonist, right? So it helps displace acute agonists, full agonists that are short-acting off of the opioid receptor, theoretically leading to lower risk of respiratory depression and fewer withdrawal, less euphoria when patients take, short-acting full agonists when they're already on this maintenance. However, there's a big problem with giving this particular medication to the patient in the stem. Can anybody identify the problem?
It's PO and he's vomiting.
Yeah, so that's one big problem, right? A practical problem, oftentimes overlooked. I'll take that, right? It's kind of like, what about another one? Okay. So this patient's on methadone maintenance, right? So patients who are on methadone maintenance, if you talk to enough of them, none of them are interested in taking buprenorphine, right? For the most part, these are patients who are already proven themselves to be either not tolerant of the medication or have lifestyles that are not compatible with buprenorphine and naloxone. Sometimes it's because they were simply not offered the drug, but transitioning a patient from methadone to buprenorphine and naloxone is tricky because of the possibility of precipitated withdrawal. That's not only, you know, potentially moderate to severe, but also long lasting, because both these medications are long lasting, right? With the durations of action lasting, you know, in the measures of days, depending on how much of a dose that you take. All right. It's not so much the naloxone that I'm worried about here. It's not available sublingually, right? It's not bioavailable sublingually, but it's the buprenorphine itself knocking off methadone from the mu-opioid receptor that can present problems in these patients that can lead to, let's say, extended lengths of stay in the ED or just an overall bad time in the community. Okay. What about clonidine? How many of you guys would give clonidine to help this patient? Clonidine, maybe some, you know, some ondansetron or metoclopramide. So it's plausible, right? I think many institutional protocols do call for clonidine, 0.1 milligrams QID, TID, PRN, right? It's a great medication for normalizing vital signs, right? Along with that, perhaps not surprisingly, it's associated with postural hypotension at many of the doses used, which may not facilitate discharge from the ED, which is not ultimately the goal, but let's be honest, it's kind of the goal, right? None of these patients want to live in the ED either. But what the, you know, I don't want to say study after study, but anecdotal experience after anecdotal experience and large cohort studies repeatedly shows that clonidine is pretty poor in terms of managing the somatic, you know, effects, the somatic symptoms of opioid withdrawal. So nausea, myalgias, dysphoria, abdominal pain. Clonidine doesn't really touch these, right? It's really not doing a service to your patient, I feel, by giving these patients clonidine, unless they're really hell-bent on avoiding all opioids as a kind of categorical, you know, option. But in this patient, you know, this patient's on methadone maintenance, right? The guy didn't just decide to stop methadone one day, right? He took an unknown pill, probably naltrexone or naloxone, which was given to him either unwittingly or you know, maliciously by you know, a person. And you know, this case of precipitated withdrawal needs to be treated. Otherwise, electrolyte imbalances, hypokalemia, hypocalcemia that precipitate perhaps torsade de pointe could be in this patient's horizon, right? So what I would do is I would give this patient a parenteral opioid, right? You can choose sub-Q, but you know, if you're gonna go titratability, right, you might as well just give IV. And titrating with a, you know, relatively high potency pure opioid agonist to facilitate, you know, anti-emesis, to facilitate comfort, so that the patient can eventually tolerate a medication of their own, right? Methadone in this case, I think would be the ideal way to manage this patient's multi-system complaints, right? You could try, again, a piecemeal approach with Tylenol, Maxiran, Zofran, Haldol, IV fluids, right? You know, NSAIDs even for myalgias and withdrawal and hemodynamic complaints, but why, right? It's not a moral failure, right? To prescribe opioids to a patient who's already on opioids and who hasn't said that I don't want opioids under any circumstances. Some patients are like that, right? But I find the vast majority of them are not. They just want their symptoms to be better. And this patient's like, you know, the golden example where the patient was just maliciously kind of given what sounds like a full antagonist of the opioid receptor. But there's other edge cases where, say, not edge cases, more common cases where a patient comes in with a medical problem, right? They're on maintenance therapy with methadone. And while getting treated for a cellulitis or an abscess or sepsis, they develop opioid withdrawal. How do you treat this patient? Just re-prescribe, right, their home medications. What if they're on heroin? You're not going to prescribe them heroin, right? Yeah, well, in that case, I prescribe methadone, right? And hopefully you catch it early so that you give a, you know, a low enough dose to stave off withdrawal without causing sedation down the road. The typical starting dose I use for patients who are, you know, pretty well accustomed to quote unquote heroin, which usually contains fentanyl or ultra potent fentanyl analogs now, is 10 to 20 milligrams PO, okay? In New York, they use sub-Q or, intramuscular methadone quite frequently, okay? But we don't have parenteral methadone formulations in Canada so much, so PO is the best you got. In this particular study, it's a retrospective cohort of patients who got IM methadone per Bellevue protocol. The COWS score pretty reliably decreased in the first few hours after administration of IM methadone, right? It's by no means an RCT, it's not even prospective, but it has a lot of pharmacologic, bioplausibility, and it's time tested in terms of the Bellevue's patient population, which again, lacks many of the supports that are needed for long-term care. They don't have a GP, they don't have good health insurance, they probably don't have access to a cell phone even on many occasions. So you got to control these patients with kind of long-acting medications that don't just work while the patient's in the ED. All right, for the interest of time, we're going to move things up a little bit, okay? You can just type your questions in the end, we'll get to them as we get to them, all right? Type your questions into the chat box. So a young lady is brought to the PEDS ED after being found next to a bottle of Benadryl, okay, diphenhydramine. She's got a pretty classic antimuscarinic toxidrome. What are you giving to this patient? Let's say her DSQ, you do a lookup, there's no other medications on board. Does anybody want to volunteer a response? It's no big deal. Physostigmine, okay. So physostigmine, it got a lot of play, arguably too much play. Let's say in the 70s, 80s, where it was one part of the ubiquitous coma cocktail, right? Naloxone, physostigmine, D50, right? Thiamine. But due to some probably over-reported complications associated with physostigmine, bradycardia, asystole, this drug has unfortunately developed kind of a radioactive tinge that make us very well versed in its adverse effects, but maybe not so well versed in its therapeutic benefits. Okay, so in this population, which are relatively young, healthy patients without underlying seizure disorders and with relatively uncomplicated kind of drug histories, just like in the vignette, right? Like found next to Benadryl, or with a prescription with a receipt from Jean Coutu in their pocket saying, they bought this at X time and their overdose was 2 hours later. I exaggerate, but it's kind of a clean history like those that got enrolled. Patients who are given physostigmine versus lorazepam in an RCT setting done in kids, no small feat, right? And near immediate resolution of their anticholinergic delirium as measured by the CAM ICU score, as well as by kind of clinical gestalt, compared to lorazepam, which merely diminished the intensity of the symptoms without taking them away. These authors gave a bolus and then an infusion of physostigmine, up to 2 milligrams each time, but using weight-based dosing to get their initial dose. And compared to lorazepam, again, the difference was day and night. You see the numbers in the top right table, right? Initially, pretty much everybody was delirious in all groups, quickly decreasing to 2 out of 10 in the physostigmine group, whereas all 10 out of 10 patients in the lorazepam group remained delirious. And just in terms of the time frame of effect, you see the figure kind of outlining that in the bottom right corner, where patients, again, with randomized to the physostigmine group had near immediate resolution after the first and then followed by the second bolus, whereas lorazepam, even 4 hours out, these patients were being monitored for persistent anticholinergic delirium. These are the cleanest possible cases to give physostigmine in. It's by no means the only patients that can benefit. I think with a judicious considerations of risks and benefits, you can give this, extend the indication to many young adults, even sometimes in patients with a history of SSRI use or SSRI prescriptions, depending on the balance of symptoms upon their presentation. Okay, but I do recommend you discuss this with a poison control before you do it, or you can text me or something. Okay, I'll include my cell phone at the on the final slide. So just to give you an idea of how monumental a feat this was to recruit the 19 patients that were ultimately in the study, right? They screened 175 patients overdose in the PEDS ED, okay? They got excluded for various reasons. Most of them were just too healthy, right, to warrant physostigmine administration, but some of them were too sick and some of them were much too sick, okay? But from the 175, they distilled down to 19, right? So it gives you an idea of, even within this rarefied population, it's not everybody who comes in who warrants physostigmine. It does require, you know, a knowledge of the contraindications to physostigmine and which cases where if you give it and something bad happens, even if it's a fluke, a peer of yours is going to judge you to be way out of bounds in terms of standard of practice or standard of care. Okay, but that's a, you know, a regional decision, not necessarily an objective. Okay, moving on. I think we got 2 more slides or 2 more cases, so we're just going to blast through them. Here we have a case of pretty clear-cut cannabinoid hyperemesis syndrome. Medications to give to treat this patient with, you know, have been difficult to come across just because everything seems to be pretty ineffective. But you know, a Canadian study that was published recently in the Annals of Emergency Medicine found that haloperidol was superior to ondansetron in patients being treated in the ED for likely cannabinoid hyperemesis, right? I say likely because it's ultimately impossible to, you know, get a diagnosis that, well, I don't want to say get this diagnosis, but to exclude all organic and functional causes in a timely fashion in patients with this. Sometimes the sniff test is the best you're going to do, especially in the setting of ED context where symptoms now require treatment now, right? So in this study that was published out of Queens, right, with Roberta as the chief, you know, as the first author, and you know, Civilati, one of the you know, poison center, not specialists, one of the poison center consultants at the Ontario, you know, poison center for a very, very, very long time. They examined haloperidol compared to ondansetron, big boy doses of both, right, and intravenous, no doubt, right. Haloperidol 0.1 milligrams per kilogram. If you imagine a 70 kilogram person, right, that's 7 milligrams of IV haloperidol, right? More than what you would normally give to a patient in agitation, I would say, right? And sometimes you get pushback with haloperidol because of this big label on the front that's even on our own medication. So I think this is the same maker as that make the ones that supply the MUHC. It says for intramuscular use, right? I think in ours, it even says like, no, not for IV administration, because it's not, let's say, FDA approved for IV administration anymore. Okay. But it doesn't mean you can't give it. Most of the medications we give for toxicologic indications aren't approved by the FDA, right? But these authors examined IV haloperidol versus IV ondansetron, and based on the visual analog scale measured out of 10 centimeters, there was significantly more patients with good relief, right, with scores below 2 centimeters, right, in terms of both nausea and abdominal pain when given Haldol compared to ondansetron. Okay, ultimately, these patients again are elusive to study because you know, they don't have the best social supports. There's a lot of you know, deeply entrenched, you know, biases against them in the medical establishment. There's a sense of frustration due to the fact that many of our treatments don't work. So we feel useless, and you know, a lot of our discontent at our own, lack of utility can be transferred onto the patient. But I would try first-line haloperidol on many of these patients at the doses used in the study. You could go with the 0.05 milligram dose. It seems to be equivalent to the high dose and probably is going to get less pushback from you know, members of the care team that are skeptical. Oftentimes this is driven by nursing because of the more strict protocols that are in place there. But I would give IV maybe 5 milligrams empirically, right, and see how the patient does. This is by no means a condemnation of ondansetron. If you want to give it, you can still give it. Just be wary of the stacked QT prolonging effects, especially if the patient's been having days of withdrawal, days of potential electrolyte depletion. If you're wondering if they're very dehydrated or low on electrolytes, please just get the electrocardiogram before the patient is started on this treatment. The concept of non-QT prolonging antiemetics is a different discussion for another day. They're rare and hard to find and mostly off the beaten path, but sometimes you do have to resort to these kind of exotic antiemetics, which maybe we'll cover another time. Quickly running out of time, so this is the last talk, okay, last case. So 76-year-old person coming in with lower limb edema. after a recent diagnosis of back pain and being started on some medications. Just polling the audience, any idea of which medication this patient could have been started on to cause the symptoms? Clearly, there's an element of maybe superimposed cellulitis here. Okay, this is a picture from a case report, but the peripheral edema is new. Okay, after starting a new medication. So we're gonna bookend this, presentation with another gabapentinoid, right? Or a discussion about gabapentinoids more in general. So pregabalin as well as gabapentin are associated with peripheral edema and kind of pseudo CHF presentations. Okay, in this patient, this is a pretty well publicized case report with a provocative image taken out of Vancouver, BC. This is a lady who was started on pregabalin and developed marked symmetric lower limb edema. Sometimes it can be asymmetric, especially if the patient has pre-existing venous insufficiency that's asymmetric, but generally it is more symmetric. Okay. Just to give you a scope of the potential problem, sure, maybe only 10% or so of patients with pregabalin or gabapentin in the setting of RCTs do develop this complication, but 10% of a lot is a lot, okay? Back in 2018, gabapentin was the 6th most dispensed and prescribed prescription medication, okay, in the United States, totaling 67 million doses or scripts. I don't know what the unit is here, okay? And it's roughly stable between 2017 and 2019. How much money does this constitute, right? Using the brand name Lyrica, right? $5.2 billion were spent on gabapentin alone in the United States, collated through kind of various sources in this, healthcare, audit published in 2019. You could potentially cut back on the cost. And remember, the cost to any individual patient, especially now that the medication is generic, is not vast, right? But because pregabalin or gabapentin specifically has this widely held notion of minimal side effects while being potentially useful for a myriad of indications, it tends to just get sprinkled on everything. And as a result, we need to be vigilant about potential complications that can arise with this ubiquitous prescription, okay? So just give you a sense of what kind of complication rate there is with peripheral edema in randomized control studies. In this evaluation of pregabalin, okay, the older drug, peripheral edema occurred in up to 8%, right, of patients in the high dose group, which many patients with, say, herpetic neuralgia or trigeminal neuralgia or various peripheral neuropathies can be up to, okay? Lower doses are associated with fewer patients with peripheral edema, okay? Looking at gabapentin now, okay, again, similar amounts, up to 10%, 8% or so in the high dose group get peripheral edema compared to very, very, very few in placebo and relatively few in the low dose group as well. But if you recall back in the gabapentin for alcohol withdrawal study or alcohol dependent study, it's the high dose group that had the best therapeutic effect. And I think for the majority of indications for gabapentin, people like to push the limits, right, of the 1800 or I think it's like 2200 a day max. As a result, you're going to have a certain component of patients with peripheral edema that could be due to this medication, all right? And just to illustrate the second order effects of this, an interesting study out of a pharmacovigilance group in Sunnybrook found that recent gabapentinoid prescription is associated with tack on diuretic therapy in a community diagnosis of back pain, where patients who were given a gabapentinoid had a 50% higher risk, adjusted as well as crude, of, let's say, a diuretic use, whether it's Lasix or spironolactone or amiloride, probably not amiloride, right? But of any diuretic use in the first 90 days, as well as 180 days after, right, prescription of a gabapentinoid for back pain. This is not a causal relationship, but it's an interesting cascade effect that I think we would all be, we should all be better informed about, and maybe not prescribe so reflexively, especially if this medication is present on the patient's medication list at a high dose. So that's the last slide I have. All right, coming up on my time now. Just one final plug out there. I do work for the Poison Center. Give us a call if you have any questions about patients with overdose. I know in the culture in Quebec, it's more so for the illicit substances as well as this, the street drugs or certain, well-known players like digoxin and lithium that get the most calls. But we're available for any questions you have about any drug toxicities. Okay, or at least I am. Give me a call or a text, ideally during, daytime hours. Write down my cell phone. I'm always interested to hear about whatever interesting cases are to you, even if they're not interesting to me. But if they're interesting to you, I'd like to talk to you about it and maybe teach you some things that you can pass on to your colleagues and friends. And then if you have any non-time urgent things, just shoot me an email. There's many interesting talks conferences in various states as well as in Europe that are always looking for case reports. I've kind of grown up past case reports, but if you want a free trip to Europe paid for by the, your residency association or by your research group, this is an easy way to punch yourself a little ticket to, Madrid or something. So thanks for your time. Hopefully we can do this again in the near future. And I'm happy to take any questions in the 1-2 minutes remaining of my time.
That's awesome, Josh. Actually, we have a 15-minute break coming up here, so there is plenty of time for questions, and I'm sure people have some burning ones, I think.
Glad to hear. Perfect. Fire away.
I guess I'll start actually when going back to haloperidol with hyperemesis of cannabis. Would you just start with haldol? Or would you be doing ondansetron first?
Yeah, so I would start with one and see how it goes. And again, like the idea of rapidly reassessing the effect, right, as well as titrating your therapies is a critical concept in medicine, right? Intensive care medicine, emergency medicine, and toxicology as well. That's why IV is generally preferred for most patients who are critically ill, right? You get your peak serum drug concentration almost immediately. You get pretty rapid equilibration with the CNS, and you should get your therapeutic effect within, 10, 15, 20 minutes, or at least a pretty accurate preview of where things are going to go. Now, I think for this case, right, the RCT kept patients in a single treatment arm as long as possible. Rescue with the alternate therapy was available, but generally not for the first hour or so. So, I would stick with monotherapy. If you're using the 0.05 milligram per kilogram dose, you could potentially double that and still be within the safety margin, at least explored by this particular RCT. So I think you'd be, on grounds to repeat a dosing within half an hour to an hour if the patient's still having intractable nausea vomiting. It's not a silver bullet, right? Multimodal therapy, including with ondansetron, is probably necessary for severely symptomatic patients, because these patients were generally only moderately symptomatic. Severe cases in extremis were excluded from this RCT, right? So that's my answer for you.
This question from Dr. Myers is droperidol back or coming back? Seems like they're using it again in the United States in some places. Used to be my fave treatment for migraines. Fave.
Yeah, so no, it's not. I think it would be nice to have, right, a lot of virtues about droperidol that are it seems like it's a limitlessly useful drug with a lot of warm nostalgic feelings from staff who've used it before, as well as active people who are active in FOMED kind of proselytizing it. I'd like to have it, but listen, that's not the reality we live in. I'm not too much of an activist, so yeah, we got to learn to work with what we got. I think in the anesthesiology carts, I've seen it during my rotations there as a resident, but I was like, we have this drug? They're like, yeah, we always had it, but apparently in Health Canada, according to Eric Villeneuve, Health Canada hasn't really allowed it for ED use or general distribution.
Okay, not noting any more questions, so thanks so much for that. I think we all feel that your enthusiasm for this is infectious or toxic in a positive way. So thanks so much. So I guess everyone will come back at 10:05, and that will be when Dr. Anthony Robert is going to give us a presentation on what our role is in digital health innovations. So we'll see you in 11 minutes.
everyone.
Hey, Anthony. Everyone's just coming back from break. But yeah, in like 1 minute, I think, like I said, 10:05 start time, and then you're good to go.
Perfect. And I have till 10:30 or 10:35.
Yeah, I believe. I think it's half an hour. Yeah.
Okay, perfect.
Yeah.
I put out a survey in the chat, and people can start answering it. That'll be great. We'll have some data to look at while we're going through the presentation.
Okay.
Tell me when I can start.
I'm gonna go for. Okay, yeah, go for it.
Okay, so good morning, everyone. I'm happy to be presenting in rounds this year. So I want to share a little bit about something that I am really passionate about. So I put a chat in this, a survey in the chat. So if you can start answering that, would be nice. I'll definitely have a moment where I'm going to go to the results and take a look at them together. So if you can start now, that'd be great. If you want to wait for me to get there, that's okay. It's not very complicated. It's just to get the conversation going. Okay, so what is your role in digital health innovations? A bit of my presentation to you. I want to get you guys excited and inspired by this idea. And the punchline is the following. You have to, and you can see my slides, Dick?
Yes, yeah, we can see it. Yeah.
Okay. So punchline is this. So you have to learn to observe your clinical environment. You have to find opportunities that you can improve clinical care. You think of potential solutions, and then you can describe the problem or the needs to the IT specialist and work with them and be the bridge between the IT and the technology side and the healthcare needs. So that's ideally the goal of anybody in the clinical world who has some interest in IT. And then you have to collaborate, or you can lead, or you can champion the IT changes in your own department. Okay, so the learning objective for this is to be able to define some of the keywords here. So healthcare innovation, digital health innovation, clinical and health informatics. They're similar, but they have different definitions. And what is design thinking, and be able to use that, and also be able to explain why I believe, and you should believe, that health informatics training is important. So first, just to get you guys to better understand where I'm coming from. So I did electrical engineering before I started my career in medicine. And that was at Concordia University. And I started working for a couple of years in software development and project management. I did a master's in biomedical engineering because I was interested by healthcare and wanted to know more about it. I did my medical school at McGill. I did my emergency medicine at the UHC. And to be able to work at the UHC around the time when I was interested in working here, I had spoken to Mark Bake here, trying to figure out what would be the right specialty for me or subspecialty. And a master's in health informatics seemed very appropriate and meaningful. I'm glad I did that. Recently, I completed the certification for that. It's called CP-HIMSS. There's a Canadian and American version. And now I'm part of the ministry's Médecins Conseil for a unité de coordination des normes de interopérabilité. This means that all the data that's used in different hospitals have to have some standardization and normalization, especially going into the future. So it's a committee that I'm part of, and I'm also part of the clinical IT group where we as clinicians provide perspectives and thoughts to the ministry. Mentors and role models. So Mark Aflalo and Mark Bake have been two pillars who've been looking at data from various perspectives, trying to capture data and use data. And I've been spending a lot of time with Mark Bake and sharing office with him. So he's been definitely one of my mentors and role models. And at different institutions, we have Steve Rosenthal, Sue Sivaram, and Bernie Unger, who've been important people that I've met and had discussions with all along the way. So let's get you excited about health informatics, okay? So my perspective on this that I'm trying to share with you is that there's definitely a movement for digital health transformation or innovation, and we'll define them soon. Many projects are currently blocked by a hospital IT or ministry IT or upper management, and because some of them are perceived to have a lack of stakeholder engagement. This means all the people that are involved, from the clinicians up to the administrator, are not properly involved in providing their input, or there's a poor scope definition of the project in itself, project doesn't seem to have a clear goal or clear plan from the beginning, or there's a lack of proper requirements for the project. And this can be improved, and we can definitely work on that. And therefore, if you as a clinician are involved, you can see the inefficiencies and opportunities in your work environment. You can get a bit of formal training in these innovation aspects for digital health transformation or health informatics, and you should be part of this innovation projects. So that's my perspective. Let's go to something a broader Institute of Medicine. So you guys may have heard of this or this group. In 2011, they published a document called Health ID and Patient Safety. Essentially, they were saying that patient safety can be improved and needs to be improved. And this was during a huge movement in the US. I won't bore you with the details, but they started developing a lot of technology and setting up EMRs in the hospitals or EHRs, and that really made a big impact. And there's a lot of problems. So they said, this is a socio-technical environment. This means that the healthcare environment that we're in has people, clinicians, and all sorts. There's technology. We're using computers, softwares, and applications. There's processes involved. Right? There's a certain way of working in emergency that's different from cardiology and ICU. There's various organizations involved in the external environment, and all of this has to be taken into account. And we can definitely improve patient safety with using health information technology. The Royal College in 2020, they released a report saying that there's emergence of new careers with a technology focus. So they wanted to consider, or they recommended, the addition of a new discipline in the areas of clinical informatics, and we'll define that just with word in perspective. And they wanted two things. They wanted more of the research aspect of things, so AI, PhD programs for clinician investigators, and the clinical innovator pathway or career track that focuses on AI and healthcare. So there's definitely a technology focus at the Royal College, and they set up a new committee the last few years on data and informatics governance. And there, if anybody's interested, there's definitely currently positions to apply for. Yeah, and there's a lot more, right? The Ministry of Quebec, similar to Alberta, is trying to improve their health information technologies. They have some project called This Is Something Like. This means you're using one application. Some of you may have heard words like Epic or Cerner. So these are really, really complex electronic health records that you can do everything with. Not everything is done well, but everything is accessible in this one platform. You can look at imaging, you put your orders in, and they want to use this not in one hospital, but across the entire province, have data from every different environment. So definitely a huge technological shift. And obviously you've heard about the literature on burnout recently, saying in the last decade that the more computerization we've done in the hospitals, there's a side effect of it, but there's reasons why that can be improved. And it doesn't mean that technology is bad, it just means that technology wasn't implemented properly. And recently, and if any of you heard about, there's a lot of talk about improving performance in our hospitals and emergency rooms and decreasing wait times. There's an article in June talking about this. So, I put on a health information technology perspective, so I'm thinking that we can improve this using better tools and technology. Okay, so let's make our first definition clear. So healthcare innovation is the introduction of new concepts, ideas, services, processes. So something new of any of these types aim to improve something that you do in the healthcare, right? So the treatment, diagnosis, education, outreach, prevention, and research with the long-term goals of improving quality, safety, outcomes, and efficiency. So it's kind of become an accepted or often reported definition. There's variations on this. There's three parts: something new geared towards what you do clinically for the goals of improving quality of care. And here's another image. We as practitioners we're using a lot of technology to be able to do our work. And there's long-term goals is this. That's why innovations encompasses all these aspects of there's the patient, how they see the care, what they receive, what we do as clinicians using technology. All right. So how does one participate in or lead innovations? Well, trial and error has definitely paved a lot of way in the past. Sometimes it's well thought of trial and error, but nowadays there's more and more talk about using methodologies, and not all of these methodologies are equal, but they have been used at different levels. Design thinking, which we'll talk about today. There's Lean, the Six Sigma, and all kinds of other ones. So my first question, I'm seeing there's some answers already, so we'll look at the result imminently. So what is the link between IT and healthcare? So I want you to select one of these four. So is there no link at all? I guess by now you know. Is it that the clinicians work in a hospital and has electricity and computers? Is it clinicians use IT, meaning they have both mobile phones and computers, or is it that IT can help, right? So if I look at what you guys have said, I'm pleased to report that most of you got the right answer. One of you put the clinicians use IT, and I can see how that could be misunderstood if you didn't pay attention and read the next one. I did want just like the most appropriate. So I can, you guys see the result as well? Just want to tell me yes. Yeah.
Yes.
Perfect. And yeah, somebody just commented pick the longest one. So that's good. So we'll continue. So what is digital health innovation, right? So there's healthcare innovation that's very broad, and then digital health really means they're using digital technologies in there. So this is AI, big data, but also simple things like using a mobile app, software application, and a software that we use called clinical information systems like Oasis and Azure. Incremental innovations are those that are small improvements where you do quality improvement. You have a specific target, specific problem. You attempt to make it a small improvement, and then you can call that a quality improvement project, or it could be a disruptive innovation, which is a significant departure from the previous way of doing things. And this could be seen as the going from paper charting to electronic charting. So there's quite a bit of steps there. And an innovation, as we've seen already, isn't necessarily something new across the healthcare systems as a whole. It's something new in your local environments, right? So hopefully that's clear. There's clear definitions. So, you know, now we're moving to clinical informatics, right? So we went from healthcare innovation to digital health innovation to clinical informatics. This is not just using computers, but it's also the body of knowledge, methods, and theories that focus on effective use of information and knowledge to improve the quality and safety and cost effectiveness. So a lot of these have a similar theme, right? So a lot of quality, safety, cost, or efficiency, and so on for the care of patients. So I interpret these as using technology in a systematic scientific approach to improve what we do, which is quality. Health informatics is very similar, but if you look at the definition, it has a bit more nuances where they talk about using healthcare sciences, computer science, information science, cognitive science to assist in healthcare. Information doesn't really talk about improving quality of care or anything like that, but be just based on definitions or solving a problem, making a decision. So these are variational on definitions. So for me, the way I see it, I see clinical informatics or health informatics being relatively similar. I see digital health as being a bit broader, and healthcare information is the bigger umbrella. So we're going to focus more on health informatics / clinical informatics. So this has been known to, in the end, with proper implementation, to improve patient engagement, better access to their services or their data, and they can help reduce wait times in different ways, whether it be ER or for outpatient clinical services. They can decrease errors in medical drug interactions, they can improve performance, they can help you better coordinate care and have better access to the data. So in general, I think some of you probably do understand this by now. So how does one learn to innovate using these things? So there's different professional bodies or academic degrees or hospital-based programs where you can get either a certification, you can get a master's or fellowship in different institutions across the US or Canada. And now they're starting to integrate these programs within the hospital. So that's what we've done here at McGill with the fellowship. This is training within the clinical environment as an extension of residency. And there's now one that came out, AI for Clinician Champions. I think the registration data hasn't passed. If anybody's interested, it's 6 weeks, 1 session per week. Just ping me, I'll get you the information. It's online. It's based out of Waterloo. Based out of Toronto, UHN, and focusing on AI, but really it's how clinicians need to be involved in innovation, and this is focused on AI. So my question to you next was, which of these programs have or will have clinical informatics trainings, like all that apply? So let's see if you guys understood this or not. Okay, let's focus on one. Okay, so Psychiatry, some of you believe will have it. Pediatrics, some of you believe that as well. And family medicine as well. And a lot of you believe emergency medicine. I'm guessing you guys are aware of the fellowship that we have. Let me show you what's really going on. So emergency medicine, as you guys guessed, there's in the US, there's Tox, and they're looking at how you should have a curriculum that's longitudinal during your residency training in emergency medicine. This was in pediatrics. Again, they had a model where they had the longitudinal exposure across their 3-4 years of training. Psychiatry is also planning to develop, and they're thinking more of remote care and telemedicine as a start for them, so that they can do most of their clinical assessment from home, from a distance. And family medicine is thinking the same thing too. So it's interesting to know that, you know, it's not just me and Mark and McGill, it's actually a momentum that started, and we're among the leaders here in Canada. Next question. So let's see if we understood a bit more of the concepts of innovation. So which of the following is the building block in developing an innovation project, right? I haven't talked about much of this, but I want to see what you knew already. So is it knowing how you can make money with the project, having a creative idea or solution already in mind, having found some funding because you applied for a project, or having a team or a company who's willing to build something for you, or having clearly identified problems? Let's see here. Okay, again, most of you definitely had the right approach. So if you have a clear, oh, more answers coming in. I like it. It's too late though. So finding a team is not really the first step. Having a creative solution is important, but really you have to start by clearly understanding the problem. It's really where everything starts. Even if you have a solution to something because an idea came to mind, really need to go back and understand what problem am I still solving. And we're going to go through that in the next little bit. Okay, so design thinking is a framework. It's making a lot of buzz noise now, and they're talking about bringing this into the medical school curriculum at McGill. And it's not necessarily new. It's catchy. It frames nicely what, you know, a lot of engineering programs have thought before, a lot of you know, methodologies for quality improvement have thought already. So it starts with this. You start with empathizing with the problem. So empathizing with the individuals and the environment. So it's a human-centered approach. So you go in a clinical environment, you're an observer, you watch what's going on, you try to define, you're trying to see how they're doing things and understand what's going on in that environment. As a clinician, you're actually one of those people, so you can actually have sense into it. But if you're going to help another person, let's say a nurse came to you with a problem, or a medical student and you're no longer a medical student, or a staff, then you can try to empathize with their situation. Once you've done that, you try to define a problem that you want to solve. So the first two steps, you're really to understand the context, see what's going on, and trying to identify a problem that's very clear. After that, along the way, you get to ideating. So this means that you're starting to think about how you can solve the problem, come up with ideas, you brainstorm and see which of these solutions makes the most sense, and you kind of carve out a good idea to solve the problem. Then you kind of prototype. So prototype often is not in the real world. It's actually in the laboratory setting or in the software testing environment, or is on paper. You come up with a prototype based on your type of project, and then you test it out. You can test it out, again, not in the real clinical environment. You can do it outside. You can do it in a simulated environment at a sim center, or set up a scenario, a sim session where people are going to test out your solution and see what happens to it. And then you kind of go through the cycle. Okay, did that work? Was that a good idea? And you keep going through, and then along the way you implement this in the real world. But this is where you start coming up with the problem, and then you come up with a solution for it. So we're going to try to solve this together. Okay. So I'm going to present to you a scenario, and you guys can just write in the chat, what do you think is one big problem that you solve here? And there's no one answer, but I have one answer to which I have a solution to that I'm going to show. So meet Dr. Sam Doe. He's a new resident that joined the team. Starting his first day of residency, he's excited, but yet a bit scared. He comes to you saying, hey, you guys have been around for a while. Tell me more about this residency program and various electives that you have. And he wants to, so you sit down with him, you start explaining the details, and they tell you this. I don't really know how to use any of these software systems. You know, I'm presenting you a scenario here and I'm stopping here. Tell me what are one of the problems here that you see that you think needs to be solved. this is your, I'm empathizing with Sam Doe here, and I'm asking you guys to come up with a problem. So you can put that in the chat. So the survey is for something else. So here, I just want you to type in the chat which you guys can think of a problem. It's not getting emails, okay? That's a potential problem. Then you get the training information and so on. Yes? Anybody else? Then Becca has his thoughts. Okay. I'm going to say that most of you are sleeping, or there you go. There it comes in. Okay, so not everything is in one place. It's different systems. That's the orientation. Excellent. So I'm going to take Becca and Audrey's answer, and I'm going to say the measure training is online. So we've developed this over the last 3-4 years. The problem that we're trying to solve there was the following. Not all learners could attend day one of orientation, or in this case, see their emails about the training. We required multiple sessions. It was hard to remember for these trainees after just one session in person, what were the specifics of that particular aspect of the training that I forgot. So how do you get that information again? Definitely ask your colleague. And then they needed to retrain sometimes because they're back after a year or several months. So the solution was to provide training online. I'm sure most of you have seen it at some point. It's online, it's at any time, it's on demand. So this is how we came up with a solution that solved an initial problem. So here I'm just focusing on the problem. So now I want to see if you understand some concepts here, and we'll clarify if you don't. So you've answered this story, but go ahead if you haven't. Which of the following is a potential innovation related to clinical informatics, right? So I'm putting the right words here. Focused on hardware. So I haven't explained what hardware is, but I want to see if you understand. So buying new computers, and you can select all the ones that apply. So buying a new computer, or changing the hospital network speed, setting up a new workstation on wheels, touching your screens, identifying patients, doing a focus using barcode scanning, or decreasing the number of mouse clicks to complete a specific order. Okay, so I'm going to look at the result here. Okay, so which of the following? So okay, this is great. So we can talk about this. So there's 3 parts of this question, right? Innovation, which I think most of you do understand a bit by now. It's something new, it's something that's improving. So all of these fit that, incremental or advanced. And then we have clinical informatics. So all of this, let's touch up on it. The key here was focusing on hardware. So decreasing the number of clicks, which a lot of you answered, is a hardware-related clinical innovation, is not, because here, the number of clicks is a software problem, right? So the hardware is the mouse, but it's not the mouse that you're going to really change, is the interaction with the system. So 1 click to complete it versus 3-4 clicks and a signature and a few more clicks is really a software problem. So software is the application, is the program that you're facing with. Hardware are the actual physical things that you can touch. A keyboard, a mouse, a computer physically, the screen, that's hardware. So I hope with this, it helps understand what is hardware and software. I'm glad that it was a valuable moment. So let's continue. So hardware informatics versus clinical informatics, right? So, faster computers is an infrastructure, network is infrastructure as well. Mobile card is an incremental innovation, touchscreen as well, and then the focus detections as a disruptive innovation, whereas decreasing is not. So this is a software innovation, not a hardware. Okay, so now your turn. So in the survey, I put space for you guys to type in a couple of problems that you're facing in the last few months as a learner. So I'm going to take a look at it, and I'm going to pick the 1 or 2, and then we're going to discuss it. And then I think we'll have a few more minutes. So then we'll go through sort of a more systematic approach of looking at this. Okay, so I got 6 answers. Let's see, problems. So we can look at it together, actually. So some of this empathize, right? So describe a scenario. So scenario isn't the actual problem, but it's more the environment that caused it. So breakdown and discharge follow. Very good. So the patients leave and there's missing information. Ordering tests for patients over weekend. Yeah, very good. I like how you guys are looking at the situation, not a specific problem itself. Reading ophthalmology handwritten notes. That's more of a problem, but it can go with the communication with consultants. downtime, rebooting multiple times when a shift server is down. Okay, so it's more of a infrastructure scenario problem. So I like some of these. I think you're on the right track. And then let's look at the problem itself. Yeah, so handwritten notes, slow computers. Okay, so that's good. And let's look at some solutions you came about. So all clerks have access to outpatient booking system and can book. So that's good. So this follows the theme that somebody mentioned before, the outpatient breakdown. Protocols to enhance streamline investigations, very good. Fewer forms, fewer acronyms, easier to use softwares, less clicks, better voice recognition. I don't know if this was some of our senior colleagues who've written this, but this is very good. My take is on transitioning to computers properly, take serious investment in dollars, manpower that we are experiencing, probably shortage. The frustrations involved can be, I won't read this word, rolling out things in enormous ad. Okay, so I think that I get the point here is that things are costly, things are not done well, things need more funding and more stations. Okay, so, I give you a pass for having attempted this. So let's go more systematic through the next 5 minutes, okay? So one approach is to think of your interaction with the clinical environment. So we're talking about you come into a hospital environment, you sit down, you log into your computer, you may pick a patient, you may review the chart briefly, you may put in some order entries, some medication labs, you may communicate with other people that you work with, you may document, you create your own documentation, you may reassess the patient disposition. Throughout all these steps, all these moments of your clinical work, there are times where you may have some moments of frustration or a challenge or an opportunity to make something better. So let's look at this a bit more specifically. So when you come in and log in, many of you have brought this up to me before, that there's a lot of Oasis and Medj logouts, timeouts that happen, and you may forget your password. So a project that we have done is called the single sign-on, which most of our events will be set up with. It helps with this problem, right? So it helps remembering your passwords because it's all recorded and you can simply swipe your card and it'll automatically log into different apps that you use. You still have to launch it. I know at the Jewish General, it launches the app already, or the app's already launched, but I have a slightly different version of the UC. And for the timeouts, there's reasons why there's a certain timeout, but I think there's definitely opportunities to improve it. So, right, that's a problem that a resident can take as a project and say, look, I like to work on improving the challenge with timeouts, and we can make a project out of it. And I don't know if you guys have heard about it. There's a fellowship, there's electives and an area of interest that you could do, and this could turn out to be one of your projects if you're interested in working on it. You can go through this systematic approach to solving it. So related to PEC and reviewing the chart, I'm describing here some of the more of a scenario / problem is that you went to recess, but you forgot to click the patient, right? So that has happened. Which service admitted the patient last time? So you want to look at the chart. You have this focus question. When was the last visit? And so these are things that we can try to find ways to improve and facilitate, by overall decreasing clicks and having the information readily available. I think some of you mentioned already. So order entry, so meds, labs, having to retype each meds in the DSQ is a problem that we all know. We're working on it. It's a very complex innovation because it involves a lot of parties, including the government and the hospital and an industry partner. And it's not easy to get to, but we've been working on it. Rest assured, we're gonna get it one day. It's just a matter of when. Multiple clicks to treat migraines, right? So let's say you often prescribe I'm going to give a random cocktail here, Advil, Tylenol, Maxiran, for example, and that's 3 meds that maybe you could click in one shot and have all those 3. So it's a protocol that you could use or you could develop. So if some of you are interested in working on protocols, come and find us. That could be an interesting project. Having to manually order a second trope, right? That's something that we know that is an issue that happens a lot. Sometimes it's delayed because of that. Or D-dimer was not ordered with a collective order. And right now, nurses are not allowed to order D-dimer. But this could be an interesting thing to look at. And maybe we have clear, easy to use methodologies that enable that. Or which antibiotics use. We have the MUHC antibiotic stewardship, which you can find on MUHC ASD website. That's one great place, but there's more things that we can do with that. A UTI for LW75, the guideline doesn't tell you what's the best antibiotic. So there may be ways we can use it in the EMR to decide. We can go through a couple more here. Communications with the clerks, they're not always at their desk to page for you. You have to sit and wait for the callback from the consultants if you don't have a spectra. You don't know if the nurse did the bladder scan. What was the plan from the consultants? You have to go dig the chart or search an OASIS. Your clinical documentation, some of you mentioned this already, and then reassessment. What was the problem that we're focusing on for this problem between sign over and so on. We have the sign over tool that staff use. So that's an example of a solution. Sometimes you're looking at the ECGs. Where are they? They're electronic. They're in the chart. They're on the desk. They're lost. Or what was the focus image of your colleague before? So these are all opportunities that you can find a specific problem. I'm going to stop here because my time is running out. And then once you have this for any one of those moments, and then you pick the problem you want to focus on, and you kind of come up with a solution, and you come up with a prototype, and then you try to test and improve. So, I've mentioned some of these projects that we're doing. So we have, and some of them are in early phase, and some of them have advanced, but these are all ideas or somewhat advanced projects. So patient in the waiting room, we can interact with them, we can give them information, there's questions that can be done. You can leverage that time. Analytics for yourself to know, how many patients you saw, or what happened to your patients, do they come back? Or clinical analytics, right? Are you prescribing the right antibiotics? Are you having the right diagnosis? Sign over tool, having smart notification alerts, improving the workflow of the DST or ECGs, and having a mobile cart maybe with a touchscreen. So that's a project that's in the works. If you're interested in identifying, is it better or faster to have a touchscreen than clicking? We could definitely study that. And improving templates for voice recognition, order sets, and so on. So this is all parts of clinical care that we found a project that can definitely improve how we work and how we care for our patients. So I can open the floor for questions if I have time. Jake, let us know. And if you get interested in doing an elective or doing an area of interest or do a fellowship, reach out to me, reach out to Adam Gossek, who's our fellow who's graduating eminently, on the chat, and or Market, or as well, you can ask the question to the different site at different sites. There's Rick Ma, there's Adrian Flory at St. Mary's, and there's many of them at the Jewish, including Bernie Unger, Steve Rosenthal, and Lars Grant, Raphael. So I'm going to stop here. I'll take questions, discussions, or if my time is up, let me know.
We have time for questions if anyone has any burning questions here. Okay. All right. Well, thanks so much, Dr. Robert, for that. Thanks for the resources as well for us being able to get in touch with you if we have more questions about the fellowship and elective opportunities and such. So thanks a lot for that. Okay. All right. So we'll move on to the next presentation. So we have Mustafa, who's going to be giving us a presentation on a Cardinal topic. So the floor is yours, Mustafa. And it looks like you're busy at home as well.
Yeah. The electricity just got interrupted in my home, so I'm using my phone, and I'm in my kids' room because it has better lighting, so you guys can see me.
Intense, yeah.
Yeah. So good morning, everyone. My name is Mustafa. I'm one of the residents at R5. For the ones who don't know me, I'm just gonna share my screen. Do you see my screen?
Yes.
So I'm gonna talk about GI bleeds. Give me a second, let me set myself up. You see my presentation and you see my mouse?
Yeah, I can see your mouse and your presentation.
Perfect, so I'm gonna start. So I'm gonna talk about Rosen's chapter on GI bleeds. So I will start it with the case. Some of you guys may have heard about this case. It was 3 a.m. at the Montreal General Hospital. I was with Dr. Levine. We had an 80-year-old male who came with massive bleeding from his rectum. His blood pressure was around 70s or 80s. However, he was maintaining well. His wife told me he just had EVAR, which is a non-invasive or minimally invasive procedure to fix AAA a few weeks ago. So at this point, what should be your differential diagnosis? What is the most thing you are worried about in this patient? And how are you going to manage him? Any ideas from the more junior learners? Could he be having a fistula, or is it too close to the surgery? You mean aortoenteric fistula?
Yeah.
So yes, so that was our main worry and differential. And then what would we have done for him?
Imagery with contrast to see if there's a flush in the bowels.
Exactly. So that's what we did. But first, you have to stabilize him. So that's what we did. So that's what we're going to talk about. So excellent, Antoine. So my goals from this talk is to give some definitions for GI bleeding in terms of the site, massive versus non-massive, because this mental model will change how you approach these patients. We'll try to identify an approach to GI bleeds and discuss some basic elements on the management. My sources are mainly from Rosen and UpToDate. So to start with, GI bleed can be divided into upper and lower, as we all know. Upper is proximal to the ligament of Treitz, which we're going to see in the next slide. And classically, it has been divided into variceal and non-variceal. And there is, again, a reason behind this division. Patients with variceal bleeds usually are cirrhotic patients. They are sicker patients at more risk of having complications and death, and the management can be, and the management is different. Also, in terms of acuity, you have massive and non-massive GI bleed. You can define massive GI bleed loosely as a significant bleed that will lead to hemodynamic compromise or risk of loss of airway for the patient. So this is the ligament of Treitz. You could see it's a ligament that divides or comes in between the duodenum and the jejunum. So that tells you upper GI bleed is bleeding from the esophagus, stomach, and the whole duodenum. Bleeding lower than that is classically called lower GI bleeding. So these are some of the common causes of GI bleed that are depicted in Rosen. So for upper GI bleed, as we all know, peptic ulcer disease, one of the most common causes of bleeding. Worth to mention that if you have a gastric ulcer as a cause for the bleed, you need to rule out a cancer. If you have a duodenal ulcer, rarely it's a cancer. Gastric erosions that come with alcohol intake, stress, varices, which we're going to talk about a little bit. It's worth mentioning that there are esophageal varices, as we all know, but there are also gastric varices, which can present in patients with cirrhosis, and their management can be quite difficult. Malarial waist tear, classically after binging and vomiting multiple times, a small tear in the esophagus or gastroesophageal junction, esophagitis, and gastric cancer. For children, almost the same causes. And then if we go to lower GI bleeding, anorectal sources are one of the most common. Diverticular disease is the most common cause of non-painful lower GI bleeding. Angiodysplasia, colitis with all its types, inflammatory, infectious, ischemic, a neoplasm, which is our main concern in elderly and patients more than 40 years old who are stable and bleeding, and upper GI bleeds. If they are brisk enough, they can present as lower GI bleeds. For kids, anorectal fissure, infectious colitis, inflammatory bowel disease, and intussusception and Meckel's diverticulum. Big killers that Rosen mentions, one of them is aortoenteric fistula, as Antoine mentioned. Think about it, in any patient who had aortic graft or has a AAA, mortality could be 100% if the patient is not treated. Worth mentioning that some of these patients will present with what's called a sentinel bleed, where they're going to bleed a little bit and then the disaster will happen afterwards. So if you have a patient who has a recent aortic surgery or had aortic surgery in the past, in their history, think about this, as you may be able to save this patient if the cause was an aortoenteric fistula. Variceal bleeding, as we mentioned, it happens in cirrhotic patients who don't have much of reserve to begin with. If their cirrhosis is advanced, and mortality can be up to 30%. So some of the presentation for upper GI bleeds, hematemesis, as we all know, is bleeding, vomiting like fresh blood. Coffee ground vomiting is as depicted here in the picture. For the ones who didn't see it in real life, if you have your coffee machine, the ones that use bags, after you finish filtering the coffee, what's remaining in the bag looks exactly like a coffee ground vomiting. That's why it's called coffee ground. Melena, which is a black tarry stool, which happens because of digestion of the blood, and it usually denotes an upper GI bleed source, and hematochezia, which is a fresh blood. So this is in terms of presentation of the bleed for upper GI bleeding. What about lower GI bleeding? Any one of my colleagues can tell me, what do they think? No one?
Bright red blood per rectum.
Yeah, what about Melena?
Usually you've passed the digestion and the acids of the stomach, so it should not really be there for lower GI bleed.
Yeah, and I asked this question for a reason. So if, Antoine, if you have a patient that had Melena and GI scoped him from the stomach and they did not find the blood, you'll say this is not a lower GI bleed. You guys don't have to do colonoscopy. That's what you're saying?
I guess.
So again, there is a reason I asked the question.
I would say like also some guy who has epistaxis, posterior epistaxis, swallowing blood will comes with the Melena also.
Yes, Hamid, this is a very excellent point. As part of your approach, you need to rule out other causes for bleeding rather than just a GI bleed. Very excellent. And Antoine, sorry, I didn't mean to put you on the focus. What I tried to say is rarely, in 5% of lower GI bleeds from the colon, we're talking about the colon, you can have bleeding as Melena. So if you bleed from the right side, not you, I mean the patient, if the patient bleeds from the right side of the colon, they can have Melena rarely. So still think about it. So that's number one. Two, we defined lower GI bleeding as bleeding post the ligament of Treitz. So post ligament of Treitz, what do I have? I have the whole small bowel. So this still can be bleeding from there. So these are your two sources that you need to think about if the upper GI scope comes back as negative. So this is a busy slide, but we'll go through it point by point. But these are the elements you want to ask in history. And we're going to discuss this in the approach. But when you see a GI bleeder, the first question, you have three questions in your mind. The first question, is this patient stable or unstable? Am I dealing with a massive or non-massive GI bleed? Because your approach is going to be different. Then, is the bleeding upper or lower? And what are the risk factors? And then your third question is this bleeding significant or not? So it is not massive, but is it significant that this patient needs further investigation, or is very minor bleeding that the patient can go home after observation? So these are your three main questions that you ask yourself while doing all of these questions. So you're going to ask how many times, for how long have you been bleeding for? What is the quantity? When was the last time you bled? And this question is important clinically. Why do you guys think it's an important question that may change your management a little bit? No one?
I mean, I can say it might give you a sense if he's bleeding. Like, if, for example, if the last time he bled was an hour ago, it could give a sense as an ongoing problem that could potentially become worse. But if, for example, the last time was 2 days ago, then that's a bit reassuring that nothing is bleeding currently, maybe. Does that make sense?
It makes sense, and I'm going to say it in a different way, and maybe it was kind of say what in my mind question, but blood is catheteric. In other words, blood is like taking laxative. So we face this clinically. The patient came, he or she bled, let's say 4 times, had bloody stools 4 times, 4 a.m. in the morning. And then they came to you, let's say at 10 a.m. and they said, for the last 4 hours, I did not go to the washroom. That means most likely they stopped bleeding. Because if they were bleeding, they're going to go to the washroom. Blood is catheteric. So that's the importance of this question. It could tell you that the patient most likely stopped bleeding. But put in mind, they can bleed again if the cause is there and not treated, depending on the cause you have. For example, the vertical bleed, 80% of the time they're going to stop by themselves. So that's the importance of this question. Is the patient passing any clots? And the importance of this question in any case in medicine in general, if the patient is bleeding with clots, with the blood, it denotes more significant bleeding. If there is any abdominal pain, so if the patient has abdominal pain, you have a differential to think about. You have gastritis, you have colitis, you have IBD. Does the patient have fever? So the fever will also direct you to a different differential. So does the patient have IBD? Does the patient have ischemic colitis? Does the patient have C. diff? Is there is vomiting? So vomiting, then blood. You'll think about Mallory ways. Any history of GI bleed, as per up to date, 60% of the patients that present with rebleeding have the same source as before. So if the patient is known for diverticular bleed, there is a good chance that this is a diverticular bleed again. If the patient is known for peptic ulcer disease, there is a good chance this is a peptic ulcer disease. It's not at all carved in stone, but it's a good rule. Is the patient on any aspirin or anticoagulation? These are the most important kind of questions. Box 27.3, the next one here, and Rosen, is almost mirrors the same questions we discussed here. The other box that defines the more high-risk GI bleed, so medication use, aspirin, NSAIDs, steroids, anticoagulants, history of peptic ulcer disease, known liver disease of cirrhosis, advanced age, alcoholism, chronic smoker, any chronic medical morbidities, because these patients may not have enough reserve to tolerate the bleeding, and then history of AAA, as we mentioned before. Your physical exam, you want to monitor the vitals, keep in mind some elements. So again, when you do the physical exam, your first question is this patient stable or not? Do I have to jump or I have time? Pulse, tachycardia, our first response to shock. Keep in mind athletes, elderly, and patients on beta blockers may not mount tachycardia. Blood pressure, hypotensive or not. The first response to shock is tachycardia, and then narrowing of pulse pressure. You could see on the patient that the systolic will stay stable, but diastolic will go higher because of the vasoconstriction. So if this happens, and this is what's happening in my patient, the one with the lower GI bleed, initially the pressure was normal, then high pulse pressure, and then he started to lose his blood pressure. You know that you're advancing in your shock. Or SAT and fever, as we mentioned before. Mental status. So again, to my junior colleagues, which is going to be the next slide, what's the value of hemoglobin and acute bleeding?
In acute bleeding,
yeah.
Let's say, you mean like if you already have a hemoglobin before, or just
this patient that I saw in 3 a.m. I sent for a VBG. I want to say his hemoglobin.
All right. So
what would this tell me?
If it's your first value that you're having on this patient and the number is normal, then it is not a good. It doesn't really show you if he is now anemic, because you lost the same amount and the concentration of whatever you lost is the same that is in your vessels right now.
Exactly.
As for somebody who becomes anemic on bleeding, usually it's just on some chronic bleeding, then the hemoglobin drops because your plasma volume actually replenishes the volume, but has not had the time to replenish the red blood cells.
Exactly. Excellent, Anton. Thank you very much. And as one of the trauma staff used to say, if you take a cadaver, like a patient that just died, and you take their hemoglobin, it's going to be normal. So as you said, acutely, hemoglobin will not much change your management, unless if the patient becomes anemic, it could be. But what I'm trying to say, and I'm trying to link it with the mental status, is you need more fast measures to tell you if the patient is acutely bleeding in shock or not. And one of them is mental status change, sweating, cold extremities. So yes, excellent, Antoine. So and then signs of liver disease, because you want to gauge if the patient is at high risk of having varicose bleed or not. Examination of the abdomen, if there is any signs of peritonitis or not, because they can have perforation with the bleed, they can have colitis, etc. And DRE, and I put it in question mark because Rosen recommends doing a DRE, and we all know in clinical practice we don't do it that much. My very simple understanding for this, and I could be wrong, I can think about two indications to DRE in this context. One, if I'm not sure there is a GI bleed, like upper GI bleed occult, then I may do DRE to see if there is melena, and if there is, I may do the fecal occult test. My other indication is if I have a lower GI bleed, so hematochezia in a stable patient, and I don't have GI support soon, and the patient is more than 40, then DRE is indicated to see if there is a rectal tumor that you can feel. So now you're going to tell me I'm going to send the patient to GI regardless. Yes, if you're in McGill, you have good support. But if you are outside, you don't have long support, the patient is going to be seen a long time, you may pick up a rectal tumor. And you may make the patient being seen fast. These are the two indications as far as my very humble understanding goes. If anyone has any other indications or had any other thought, you guys can share.
Sorry, Mustafa, I just have a quick comment about the hemoglobin. So like typical textbook teaching is that it takes about 6 hours for the hemoglobin to sort of equalize, or for fluid shifts to equalize to reflect what the actual hemoglobin is. But talking with anesthetists, they tend to use the hematocrit in acutely bleeding patients. Just wondering if you have any comments about the hematocrit specifically, or if it's my assumption was that it was similar to the hemoglobin in the sense that you have to wait for the fluid shifts to adequately reflect, but the anesthetists seem to like using the hematocrit instead.
Well, thank you, Audrey. To be quite honest, I didn't pass any literature that discusses hematocrit, but being with the trauma people and when we're assessing traumas, especially when you talk to Dr. Razik, they were not discussing hematocrit or hemoglobin, and they were depending more on the clinical parameters.
All right, thanks.
No worries. So now, is it an upper or lower GI bleed? Sometimes it could be tricky to decide. There was a meta-analysis that suggested if the patient reported history of melena, if you saw melenic stool on examination, if there is blood or coffee ground detected during nasogastric lavage, or if the ratio of blood urea nitrogen to serum creatinine greater than 30, then you're more likely to have a lower upper GI bleed. And the reason of the ratio is the blood get reabsorbed in the GI tract and will cause higher urea level. If there is clots with the stool, then an upper GI source is less likely.
Quick question. I know we don't use. I haven't seen urea in the basic workups we do at the MGH, or like, would you actually ask it specifically in the case of a GI bleed?
Maybe if it's not clear, to be quite honest, this is the literature, but yes, so you're right. In practice, I haven't seen it being used a lot. Because most of the time, your other measures can help you. So upper GI scope, if you're not sure, you can use other tests, and we're going to discuss this more.
All right, thanks.
No worries. The other question that I expected you're going to ask me is nasogastric lavage, which we're going to discuss soon.
Yeah, but I have like regarding the urea nitrogen, maybe it could be like sensitive but not specific for the upper GI bleed. Like it could be raised from another causes also in the same patient.
Could be. If the patient is, you mean, for example, having epistaxis, digesting their blood, so it could be not a GI bleed. That's what you mean.
Yeah, exactly.
Yeah, it could be possible. Again, it's about the whole picture. These factors will help you, but it's about the whole picture. Is that okay? Okay, I'm gonna move next. So back to answer the testing. So Rosen mentions the GOYAC bedside test. Again, in clinical practice, I don't see it being done a lot. And one of the reasons is your clinical impression of a GI bleed should override any testing. That's what Rosen says. But if you are not sure, maybe you should do it, the GOYAC bedside test, keeping in mind that there are causes for false positive and false negative. So it's the whole clinical picture of the patient. Lab testing will help you to risk stratified GI bleed. So hemoglobin, platelets, coags, creat, urea, and type and screen, and VBG. LFTs if you have a patient, you're worried that you have cirrhosis. AKG is recommended if you have a patient who have history of cardiac disease, if they're elderly, because the GI bleed could strain their heart and they may have cardiac ischemia. So for imaging, there is this table in Rosen, which I don't know how useful it is, but because it's Rosen, I'm mentioning it, and then I'm going to discuss more the imaging when we discuss the approach. So they quoted the American College of Radiology appropriateness rating scale, and they were giving each imaging modality a scale from 1 to 9. The more the rating is, the more appropriate the scale is for your imaging. So they said a transcatheter arterial intervention is 8. It's cool, it's good because you can angioembolize, but we don't really use it much in real life unless if we know the source of bleed. Colonoscopy is a 4 because you can go, but maybe challenging in an unstable patient. Surgery, yes, but appropriate if bleeding site localized. Nuclear medicine, not very useful in the acute setting because you use it only in a stable patient. CTA, we go to it, they give it a 5, but if you have an acutely bleeding patient, it's good. MRI is not very good. And we're gonna talk more about this when we go through the approach. So NG lavage, the reason I think it's interesting to mention here, when I was in my shifts recently at the Glen, we had some GI consults for patients with melena, and one GI fellow was asking to do NG lavage, which triggered the discussion again. How useful is it? It has poor sensitivity and specificity. So one of the patients, we put the NG, and the nurse came and she was like, I see fresh blood. I wonder there was fresh blood, but the patient was stable. So what happened is, because of the NG injury, there was irritation to the stomach or esophagus, and there was some blood that came out. So it doesn't have very good sensitivity. If we saw melena, then okay, we know there is upper GI bleeding. But if the patient has melena, you need to scope regardless. The only condition that is suggested in the literature that may be useful to rule out an upper GI bleed is if you have bile coming back. And the reason is, if you put the tube in, no blood is coming out or melena, then maybe you have rule out the stomach as a source. But post-pyloric, which is part of the upper GI tract, maybe you still didn't rule it out. But if you have bile, which bile comes from the duodenum refluxing back, maybe you have ruled it out. But really, nobody really recommends it. If you think there is upper, you have to do an EGD. The use for it is, however, if there are lots of clots, if you want to help your GI colleague before scope, you can do lavage to clean the stomach. So when they go in, it can be clear. Your other solution, if you don't want to put a G-scope, is to give erythromycin, 20 milligram IV, 30 minutes before the scope, which is going to trigger stomach contraction, and then you may clear the stomach. So we have 2 solutions to clean the stomach. So diagnostic algorithm, again, you want to see if the patient is stable or unstable. You want to define the source, and then you want to go to the severity. If the patient is unstable, you're going to jump on the patient, 2 large bore IV lines, or a cordis if you can, not triple lumen, IV fluids or blood if you need. Your target hemoglobin should be more than 70 in most patients. If the patient is cardiac, as we know, you may aim higher, more than 80. If you start the massive transfusion protocol, aim for 1 to 1 to 1 ratio, which is 1 packed RBC, 1 FFP, 1 platelets. Your goal for systolic is 100 as per Rosen, and clinically, so adequate perfusion of the skin, no metastasis, and good urine output, which is 1 milliliter per kg per hour. You should avoid intubation if the patient is hypotensive, as we all know, because it can trigger a cardiac crash or more hypotension. If you need intubation, you may need it for massive GI bleed, like in varicose bleed, to protect the airway, or if the patient has altered mental status and they're bleeding, again, you want to protect the airway. Then you're going to determine if the source is upper or lower, and then you gauge your severity. So if you have an upper GI bleed, so the patient is vomiting blood or you have melena, as we all know, you're going to start a PPI. And one of the main uses of PPI, or hormone usefulness of PPI, is to reduce the rate of rebleeding. So you started the PPI, the gastroenterologist went to scope, they found the ulcer, they injected the ulcer, they controlled the bleeding. There is a rate of rebleeding, but having PPI will decrease this rate. There is 2 dosing regimens. The one we all know, the drip, Pantaloc 80 milligrams IV followed by 8 milligrams for 3 days. This is recommended if you have a breast bleeding, but if you have a small bleed and you don't have much IVs, you want to give medications, you can go with a regimen of 40 IV BID. For octreotide, octreotide is a splanchnic vasoconstrictor that will reduce portal hypertension. So its most use is in variceal bleed. So if you have a patient with liver stigmata or have known to have cirrhosis, you should start PPIs and octreotide. Now you're going to ask me why PPI? Because 50% of the patients with liver cirrhosis, when they have an upper GI bleed, they can have it because of an ulcer. So you still didn't rule out an ulcer. So you start the PPI, octreotide for these patients. Motility agents, as we discussed, and antibiotics. And antibiotics are indicated for patients that are cirrhotic, because 20% of these patients, when they come to the hospital, they have an infection, and 50% of them will develop it during hospitalization. So one of the medications that can change your outcome for these bleeders is an antibiotic for cirrhotic patients, regardless of the cause of their bleed. So if it's an ulcer or a variceal bleed, you start them on ceftriaxone. Endoscopy is diagnostic and therapeutic, and I'm going to go one slide back, and I'm going to ask my junior colleagues. So for variceal bleeding, if the patient is unstable, for both variceal and peptic ulcer, and now we're talking about upper GI bleed, the answer is clear. Patient is unstable, you stabilize, you call GI, patient needs to be scoped as soon as possible. But if the patient is stable for cirrhotic variceal bleed, need to be scoped within 12 hours. But for other causes, let's say it's 11 p.m. and you call the gastroenterologist for someone who is bleeding, who is stable, upper GI bleed, vomited a little bit, or they have some coffee ground vomiting, they're stable. When do you think they should be scoped? Is it the next day? Is it in 2 days? Do they have to come to overnight to scope the patients? What do you guys think?
I would say in the morning.
Good. So what about next day? Like in 2 days or 3 days?
I can't remember exactly, but I think there was a study recently about GI scoping timing.
Yeah, there are many studies. So the recommended time for upper GI bleed, non-variceal, is within 24 hours. And they showed some studies that they will have better outcome if it's after 12 hours. So for 12 to 24, and the reason is there will be more chance for the blood to be cleared. So again, the question is the goal from it is practicality. If it's 11 p.m., they don't have to come to scope the patient. So endoscopy is both diagnostic and therapeutic. Again, we mentioned the timeline. If the patient is unstable for variceal bleeding, be sure that they are not, they have good coag studies. Your aim for INR is less than 2.5, platelets more than 50,000. Sorry, this is a mistake here. For variceal bleeding for liver cirrhosis patients, it's very tricky. And when I was reading around it, I was like, if this happens and with my patient with high INR, I'll just ask the gastroenterologist to manage it. The reason is, as we know, INR is not good reflector of the coagulation function of cirrhotic patients, and they can be hypercoagulable or hypocoagulable. It's tough to gauge. So maybe a more specialized person can determine if they need FFPs or not. The Sangiskin Blackmore tube is a tube, as we know, that's used to control the blood and variceal bleeding. So I can think about two indications. One, I'm in a peripheral hospital, someone has an upper GI bleed that are cirrhotic, and to get to GI, I need time. So to control the bleeding, I can use the tube. The other indication is if the gastroenterologist went in and they cannot control the bleeding, they can put the tube to tamponade, and then they go for other solutions. I don't know if you, for my colleagues, if I want to put the tube before, I haven't. I just read about it and how to put it. So if we have time, I can tell you the technique. But basically, the whole idea is first you have to intubate the patient. You can keep the tube up to 24 hours to tamponade the bleeding. You have 3 ports. You have esophageal balloon port, you have gastric balloon port, and you have esophageal aspiration port, which is similar to an NG tube. You want to put the tube in 50 centimeters and inflate the gastric balloon, pull it back against the gastroesophageal junction to tamponade it. And then if this is not enough, you're going to inflate the esophageal balloon. And you guys have seen all in books the picture of the American football helmet. The whole idea is because you're pulling the tube, you want to keep it under resistance. So you can attach it either to the helmet, or if you don't have the helmet, just a saline bag to keep it under tension. So alternative treatments, and it's good to know about these treatments, because if you're in the hospital, you know how to call if your patient is unstable. In case of varicose bleeding, it's steps. So you have the patient intubated, you have Sanget's tube, you call the gastroenterologist, you think the patient may need more further intervention. It's going to be either surgery with mortality of 50% or TIPS. TIPS stands for transesophageal portosystematic shunt. The whole idea is because of cirrhosis, you have decreased portal vein return because of the increased pressure. The increased pressure is going to translate as back pressure to the veins. These veins will dilate and then will cause the bleeding. So TIPS, what it does, it goes in from the jugular vein down to the IVC and tries to create a shunt between the IVC, systematic circulation, and hepatic veins to help the blood to flow back again and decrease the pressure at the varix level. For non-variceal bleeding, it's angioembolization, as Antoine said. That patient will send him for CTA, we saw a blush, we called angio, or if the patient is really unstable, then surgery. So this applies also for lower GI bleed as for upper GI bleed. And again, nowhere we are working. An example, St. Mary's Hospital, there was a case, massive upper GI bleeding, patient biliary stated, they don't have an angio person there, immediately surgery, laparotomy, he was bleeding from the duodenum, they sutured the duodenum. So it's good to know your options and where we are working, so to know who to call after you stabilize the patient. So again, just to recap again, because these were a lot of information, this is the approach suggested by Rosen. So massive upper GI bleeding, see if you need airway management, emergent GI consult with ED endoscopy. We'll add to that, as we discussed, surgery or IR, CTA as required. You have a stable patient, you have time to think. We'll go through this criteria later. But if the patient is stable and can be discharged, minimum bleeding, yes, discharge follow-up. No, then admit with the GI consult or with GI consult. For lower GI bleeding, your approach is first to rule out upper GI bleeding, as we discussed. If the patient is stable, you're going to do serial hemoglobin, type in screen, etc. Most likely, GI will see and they'll ask for bowel prep for colonoscopy the next day. If the patient is unstable, your options are CTA to see if you have a blush, surgery versus IR. I don't know why I said source not found here. But anyhow, for radiological images, first we have radionuclide scan. In our setting in emergency, we don't use this a lot. It's a test that will detect bleeding at very low rate. So you need the patient to be bleeding at that time. It picks up as low as 0.1 milliliter per hour or minute, I forgot, of bleeding. The drawback from it, it can tell you roughly where bleeding is coming from, but it can't specify the target. So for example, if you see the bleeding from the right colon and you say, I'm going to go and do right hemicolectomy, you may put the patient at risk, because what happens when blood comes in the colon or contents, they go back and forth. So you can't be sure 100%. CTA is a good test. If you again, you need the patient to be bleeding minimum at 0.5 milliliter per minute or hour, and it can tell you where the bleeding is coming from, and then you can target it either with surgery or IR, which goes to angiography. My understanding is, with the advancement of technology, sensitivity of CTA is as good as angiography, unless if someone knows differently from me. In other words, if I do CTA, I don't see it, I don't have to push for angiography for diagnostic purposes. Capsule endoscopy is, again, not very emerged thing, but the patient will swallow a small capsule that will go through the whole bowel and take pictures and can probably tell us the site of the bleeding. Push enteroscopy is a more advanced technique for GI, where they past the ligament of triads, past the duodenum, and they go a few meters through the duodenum to see if the patient bleeding from any of these sources. Again, an approach from Rosen. So lower GI bleeding, anoscopy. We don't do it a lot in emerge, but you should do a DRE, look at the patient. The reason is you want to see if there are hemorrhoids or a fissure. Keep in mind, if the patient is more than 40 years old, you can't say that the source of the bleeding is hemorrhoid or fissure, unless if you see the blood coming out from them. The reason is they could have a cancer as a cause. So if they're stable and you send them home, be sure that they're followed by the GI because they need a scope. You don't want to be the doctor that sent a patient to home telling them that they have hemorrhoids and for them to discover that they have metastatic colon cancer in 5 or 10 years, which happened before in the past. Does the patient meet the following criteria? We're gonna, so bleeding source visualized, as we discussed, stable signs, no comorbidities, no coagulopathy, young patient less than 60. If yes, you may discharge after you followed and emerged for a while. If no, then you have to admit and you have to consult and then think about colonoscopy and angio, as we discussed. So for this position, and Rosen here discusses, so at the beginning, we discussed the more sicker patients, the patients that need admission, but what about this stable patient that can go home? Is there any risk stratification score I can use? There are 2 risk scores that are mentioned by Rosen, so the Rocal score and Blatchford score. And again, use any score with a grain of salt if you're worried to keep the patient. But if the patient doesn't have any of these risks and Rocal or Blatchford score, so meaning if they score 0 in any of these scores, which are validated as far as my understanding goes, and you're not worried, maybe you can send the patient home with good follow-up. So back to the patient, yes, as Antoine mentioned, the BP improved. We did CTA and he had hepatic flexure contrast blush. And he had active arterial bleeding, likely diverticular. So if you guys remember the anatomy, arterioenteric fistula usually fistulizes into the duodenum or small bowel, proximal small bowel, because of the proximity of it to the colon. If you saw the CT image, the colon was far away from the aorta, and there was no evidence of bleeding at that time. So we identified the cause of the verticular bleed, which the patient was known for. There was discussion of taking him to surgery. This is IR, but he responded to fluid resuscitation. So he was taken to IR after elective intubation. Angioembolization was done and bleed was controlled successfully. Now, if you have a patient who had an angioembolization with IR, just keep in mind, I know they're going to be admitted. We're not going to see them likely emerge until they get discharged, but keep in mind that these patients can develop colonic ischemia after angioembolization, especially on the left side of the colon, because left side of the colon doesn't have as much anastomosis as the right side, which I have seen before. A patient embolized, ischemic, and then had to be taken to the OR. So just think about it as a complication. So in summary, as we discussed before, GI bleed, identify stable versus unstable, upper versus lower. If upper variceal, this is non-variceal, and is it brisk enough or not brisk that I can send the patient home? That's it. Thank you very much. I don't know if you guys have questions.
Fantastic. That's great. Thank you so much, Mustafa. Very thorough and very interesting case as well. Thank you. Okay. So just give me a sec. So it's my turn. So let's just get, I'm just going to share my screen. I guess I will ask you now, can people see my screen? Any issues?
I see your screen. And I see someone with the, yeah, a small guy.
Okay. Yeah. Okay. All right. So, so I figured, so I just finished doing that, like essentially a created geriatric emergency medicine elective. And during that time, I was tasked with doing a journal club entry. And then while I was doing the journal club, or preparing for the journal club, I noted that there are ways that emergency departments can be certified as geriatric emergency departments in the United States. So I thought that it would be interesting to present this to the group, and I would request that while I'm going through this, could you just put a critical thinking cap on, or hoodie or pants or whatever critical clothing you have, to just think about problems and also benefits of what I'm telling you. So I'm not pontificating that this should happen. Like what I'm about to explain to you is something that is good or is bad. It's just something that I would like you to think about as we go along, and then we can talk about it at the end. And I will try to keep this not too long in the interest of time. Okay, so why are there geriatric emergency departments? Or what is the purpose of even doing something like this? Well, I mean, I'm not going to list a bunch of reasons, but I'll be politically incorrect in saying old people can cost a lot of money in the emergency department. They stay there a long time. Their problems are not necessarily acute. You could call some of them acute presentations of something, but a lot of the time they linger, as we all know. And a study in the States in 2018 stated that delirium and recurrent falls, just those two presentations, cost upwards of $83 billion in the United States. That's a lot of money for things that, I mean, did they have to happen? Were there things that could have been optimized? So yeah, that's just a little bit of preamble. Okay, so the American College of Emergency Physicians in 2018 released an accreditation process that was based on guidelines that they developed in 2014. I'm a member, or like part of the CAPE, the CAPE geriatric committee that are developing their own guidelines. But at this point in time, CAPE just acknowledges ACEP's guidelines. And so these recommendations, deal with multidisciplinary innovations, quality improvement. And yeah, so that happened in 2018. So just to give you a general idea, there are 3 levels. And to be honest, some of particularly level 3 is really not that difficult of a level to attain. It's really just one or more specific initiatives that are reasonably expected to elevate the level of care in seniors in one or more specific areas. To be honest, it's really just some extra training and not much of that. So as you'll see later, it's about 4 hours per year. Then there's level 2, which has some more integrated and sustained senior care initiatives into daily operations. So this is where you actually start incorporating quality improvement projects to deliver senior services. You actually have someone in charge of coordinating this, and I'll go into more details later about that. Finally, you get the level 1 centers, and this is defined as EDs that actually have policy changes, guidelines, procedures, and staff, both in the emergency department and throughout the institution, which provide a coherent system of targeted care, and also measuring ED outcomes for older patients. So like actually having quality improvement metrics. So yeah, so we'll get a little bit more into specifics. I'm not going to try to bog you down with these lists, but in essence, when you look on the ACEP website for a geriatric emergency department, if you look at level 3, there's really not much that's required. So it's really just one doctor and one nurse who have focused education for geriatric emergency medicine. There are fellowships out there for geriatric emerge, but that's not what you need. You can just have 2 people particularly, who do 4 hours of training per year. Then when you start to get level 2 and level 1, that's where you start to actually have physician champions. You have interdisciplinary geriatric assessment teams, which when you think about it, the MUHC and the JGH have these teams. So again, that's where I wanted to present this to the group to have us think about this. Education, I'm going to talk briefly about just what education requirements are actually necessary for you to pass these criteria. And also then you go into policies, guidelines, and procedures. So that's where you actually have metrics and things that you need to incorporate into your emergency department to actually get this designation in terms of a model. Moving down, you have, again, metrics that you need to adhere to or at least measure. And there's equipment and supplies. And then there are just other things that I think are not really that difficult to attain, like having 2 chairs per bed. That might be difficult in the Montreal General, but I feel like in the Glen or in the Jewish, like there is room for 2 chairs. And enhanced lighting, non-slip floors. Like these are things that I think would be nice to have in any emergency department. Okay, so again, not going to bog you down with a ton of this stuff, but education, generally it's a course. I mean, there are courses like geriem.com, which in essence, I would say takes about 6 hours. It's a free website that was made by Dr. Don Milady in Toronto. And by just doing 6 hours of training, already you have qualified as having the education for a level 2 geriatric emergency department to be that particular designated physician. Nurses can also take that course. Yeah, so that's just to give you an idea of the coursework. In terms of equipment and supplies, I mean, we have these things, non-slip socks, people love those, 4-point walkers, 4-point canes, just different things that I think generally any emergency department would want to have access to. In terms of the model of care checklist, you know, it's 10 to 20 items, depending on if you want a level 1 or level 2, but these are things like having a protocol for standardized assessments and let's say triage. So let's say an ISAR, which we do have, which has been somewhat incorporated into our CTAS scoring system. I believe in a year or so, I've talked to Dr. Unger about this, but I believe that the next iteration of CTAS is going to incorporate a form of frailty risk, such as ISAR, into it, which can upgrade patients from a CTAS level 3 to a CTAS 2. Basically just a lot of screening protocols and such. So again, this is, I'm not going to go through every single one of these, but these are the different model checklist items that you could incorporate, 10 to 20 if you're looking for level 2 or level 3 or level 1 rather. Yeah, so it's quite a few options that you can incorporate. So okay, now going into metrics, you know, just looking at, you know, little things that you can measure over the course of a year. And these aren't like the most difficult things to measure. So like the percentage of eligible patients who actually receive the designated intervention, that could be if someone is eligible for geriatric assessment, did they get the geriatric assessment, or forget that, just physiotherapy or occupational therapy. What percentage of eligible patients were screened properly? You could also look into how many older adults presented repeatedly to the emergency department. Things like that, which I think are, generally speaking, not the most difficult to attain. So what are things looking like in the world, so to speak, with geriatric emergency departments in relation to ACEP's guidelines? So you have 200, actually my screen is blocking, I think it's 258 ACEP certified geriatric emergency departments. Interestingly, 2 are in Canada, and both of those are in Quebec. So you have one in Sherbrooke and one in Cowansville. And there are 2 international locations, one in Spain and one in Brazil. So I don't have photos of what these places look like, but because when I've looked into the different locations that actually have these emergency departments, they look pretty similar to what our emergency department looked like. There aren't actually many changes that are made, and that is kind of the point of ACEP's guidelines, in that they're not looking for structural changes. You don't need to build a new unit for you to get this designation. So I'm just going to go into a paper that was released a few years ago, just sort of describing what different emergency departments are out there that incorporate these guidelines. Are there any questions, by the way? I didn't. Okay. All right. So let's start here. So, okay, 4 different models were identified in this paper in the United States. So I'm going to go through each one briefly, and then we can talk about things as we go. Starting with the geriatric ED unit. So geriatric ED unit is a designated geriatric unit. Okay, so you actually have built a different unit that is meant for older age population. There are structural enhancements like different, like flooring, beds, things that we talked about in those guidelines. And you also have screening tools that have been incorporated into the CTAS scoring or whatever triaging system that the United States uses. So this is what an ISAR is, identification of seniors at risk. So it's a quick yes, no, 6-question survey that can upgrade a patient's triage score. So you look like, is your sight good? Have you been falling? Any memory issues? Those sorts of things. So advantages of having a geriatric ED unit. So focused expertise for the patient, dedicated equipment, and often structural changes to the area. And also you have a smaller initial investment in education because it's really only one unit or team that requires training for this particular unit. It's not like you have to train everyone in the emergency department to be able to do these added assessments. Limitations is that, you know, you can have difficulty triaging appropriate patients. It's not a perfect triaging system, especially when you have like a huge number of patient load as we do here. Staffing can limit these units to, you know, only being open during the daytime. You know, you won't necessarily have a geriatrician or an emergency doctor focused in geriatrics who is going to be there overnight. So then you have, so moving away from a unit, you have a geriatrics practitioner model, no dedicated unit for older adults. So the entire emergency department adopts a geriatric focused approach. So you have structural changes, screening with assessment tools that you can do to an entire emergency department. You have a geriatric nurse, a nurse practitioner, allied health specialist. This is actually pretty similar to what the access that we are lucky to have at the JGH and the MUHC. So the evaluation of the geriatric practitioners happens at the same time as routine emergency department care. And then you have social workers and case managers who figure out transitions to the community, disposition planning. So the advantages of this is that you can actually, like, you can reduce the wait time needed for these services while in the emergency department because they're actively there and they're available. And it actually has been shown to reduce admission rates. On the counter to that, you can also extend the ED length of stay. So once they actually do get assessed by these people, they can stay there longer, as I'm sure you've seen that. And I've been seeing that geriatric consults take 3 hours. And that's just the geriatrician. There's social work, there's physiotherapy that's also assessing these patients. And you can have staffing constraints that make it difficult to actually perform this evaluation. As again, at the MUHC, I know that, you know, if there's only one geriatrician covering consults, you know, if there all of a sudden happen to be 5 consults that day, it's going to take some time. Okay, so then you have the geriatrics champion model. This one is more for centers that don't have access to a lot of people. So there is no dedicated geriatrics provider in the emergency department. This is just someone who has done a little bit of extra training. That's where we go to like the Geri ED or geriem.com or something like that, where they've done some extra learning, but they're not geriatricians. And this relies on a good assessment in the emergency department and then coordination with outpatient geriatric assessments for patients. Again, there's no dedicated unit and there's no geriatrician involved in this hospital. So advantages of this, it works with small patient volumes. And when you have maybe not as many staff available and you can't afford a geriatric practitioner. However, this relies on good outpatient clinician follow-up and access to these clinicians and resources. It can be difficult to do this if the resources are not in place. And to be honest, when it was studied, it was unclear if this actually reduced hospital admissions or ED revisits. So I think, you know, this one is not as attractive. Finally, you have a hybrid, which is the geriatric focused observation unit. This is kind of a cross between the geriatric, having a geriatric emergency unit and a geriatric practitioner model. So approximately 10 to 20 beds. And I think that in some ways we have this now. You divide the patients into cohorts for evaluations that are going to be longer than the 4-hour ED stay, but they're not going to require more than 2 days. So you have patients who are deemed to be under observation. It's a status. It's not a space. You could argue maybe with not like short stay unit, because we have the short stay unit where people actually go to that unit, but you could, in essence, this is to help with numbers and it's to permit patients to stay longer in the emergency department. But for flow purposes, they're still just considered under observation. So the advantages of this is it negates the need for staffing of geriatric consultants, pharmacists, physical therapists, and social workers during evening hours. So you can basically label that person as under observation, that's their status, and they're not going to be rushed to leave once that happens. And these patients can stay overnight and be evaluated the following morning without concern for flow. The limitations, though, is who's going to benefit from this model of care. Again, identifying eligible patients is difficult, you know, in terms of you could have 2 75-year-olds who it's somewhat subjective, which one deserves this observation status versus which one can just be sent home. And the services can be diluted based on this if you have too many patients who you label as this. On top of the fact that, as we know, labeling someone under observation and keeping them in the emergency department, I mean, you feel like when you're in H2 at the MUHC, you have patients who are there for like multiple days, and that really doesn't help with flow. Even though you can say that, oh, it's good for not forcing the issue with these patients, at the same time, that's a number of beds in a very busy emergency department that cannot be used for people who are waiting in the waiting room. Okay, so again, summarizing, these were the 4 different models that up to this point have been identified by the authors of the study listed in the United States. So this is where I would like, if you can, just to start thinking about what are the benefits of this and what are the detriments of this. These are this is not an exhaustive list. I haven't thoroughly investigated the benefits of certification, even though the ACEP guideline paper that is released, as they explain why would you want to get certified. They do focus on patient outcomes in terms of like lower admission rates and lower readmission rates. You know, they talk about it is better for geriatric care. So certainly these are good things. For you could say, the holistic care of a geriatric patient who likely has many things going on, not just a mechanical fall. But I think on the side of that, when you look at what would be the benefit to our institution, well, you can say that our institution, as quoted by ACEP, you can signal to the public that your institution is focused on the highest standards for providing care to your community's older citizens. So you can showcase yourself as being a leader in emergency department advancement. And also, I figured, you know, for funding, you can use this designation as, you know, maybe a bargaining tool for getting more geriatric staffing. So if the limitation in the emergency department is that you don't have enough geriatricians to actually make this a timely endeavor, maybe you could get another geriatrician to be staffed, or maybe you could get another geriatric liaison nurse in there. However, after talking to some people about the detriments of having the certification in a system like Montreal, you might just get an influx of geriatric patients to that particular emergency department that gets that qualification. So, I mean, you're not a geriatric center. I mean, you're a tertiary or quaternary center, but you see everyone. It's not like you're a peds emerge where that's what you see. You see everyone, but you might get an overflow of geriatric complex patients to an emergency department that is already overflowing with complex patients. And the question of there being a financial benefit, from what I understand in the United States, if you get this designation, which again, this is an American designation or certification, you can possibly get some extra funding for your institution. In Canada, I don't know if I've asked around, particularly to Dr. Adrienne Brousseau from University of Sherbrooke, who is the person who got their certification for the geriatric emergency department. And she explained to me that it had more to do with just showcasing that you have taken the time to incorporate these changes into your emergency department and it looks good for your institution. There weren't necessarily financial benefits, and it's a smaller center where everyone goes to that emergency department anyway. Whereas in a city like Montreal with multiple emergency departments, there could be the issue of having all of a sudden, with a hospital that already sees complex patients, you get a ton of not just complex patients, but older complex patients. So these are some benefits and detriments that I see to having a geriatric emergency department certification. And I would love to hear, please, if anyone has any thoughts as to, do you think this would be a good thing to have? Do you think it would be a bad thing? Just out of interest.
Hey Jake, it's Becca.
Hey.
I can turn on my video. Hold on. I think that in general, improving outcomes for one specific group of patients, you're getting them out, you know, faster. They're not having as many frequent falls. They're less delirious. I mean, that's going to improve outcomes for everybody. If you're saying there's fewer readmissions, it seems like a no-brainer. I don't know if it's been studied, but I mean,
yeah,
not
like
a
I
hard
don't
thing
have,
to extrapolate.
yeah, like I haven't noted, sorry, I don't have the exact papers here, but in essence, the idea is might take them a bit longer, might take you a bit longer to discharge the patient, but the patient doesn't come back for good reasons, not for bad reasons. So the so it and I mean, my time on the geriatric consultation service, I mean, they really tee these patients up. Like when, okay, on occasion you get a patient who is seen by geriatrics who gets readmitted, but generally speaking, they identify some serious problems in patients who anyone might just say, oh, they just had a mechanical fall, they tripped on a rug, and that's it. And it's a pretty powerful team that they have at the Glen and also at the MGH. I haven't worked at the JGH on the geriatric team, but it takes more time, but I feel that in the long run, it would decrease the load. But anyone have problems with the idea, which again, there are issues with getting the certification in this country, given that the financial incentives might not be there necessarily, and there could be an overload of patients that maybe won't help your emergency department.
About that argument of the overload of geriatric patient coming to your ED, I guess it works if only one of the hospitals in Montreal or in your area actually has this certification, and the others that could be options for that population, the other hospitals would not have it. But if you have more than one hospital who is actually having that certification, sick geriatric patient, the fact that you have the certification itself doesn't mean that you're going to have more sick patient in the city itself, but they might come into your center. Therefore, if you have more than one center, all your hospitals that are already taking care of geriatric patient are just better equipped and better trained for that kind of cause. And therefore, as you mentioned before, they might have less bounce back. And at the end, I think it's, yes, a disadvantage if only one center gets it, but if you have more than one center that actually hops in, I think it's less of an issue.
Mm-hmm. Yeah, I think that's a really good point. It would be a community development within a Montreal, like let's say if we're talking in the McGill system, you know, if the 3 different hospitals got, because again, we actually have the resources to do this. You know, like when you look at the descriptions that I was given for the different models that have been identified, well, at least the 3 major hospitals that we work at have almost all these resources to at least become a level 2 center, if not level 1, with just a few improvements here and there, or quality improvement metrics. So
yeah, I mean, Jake, to be honest, unless like it's integrated into your pre-hospital system that like geriatric complicated patients should go to a geriatric place with certification, like I don't think, to be honest, it would have that much of an impact, because you know, sick old person calls 911 or family member calls 911, they bring you according to their pre-hospital triage protocols, right? So unless you somehow change your pre-hospital triage protocols, people are going to go to either the center that's close to them, the center that they know the best and they like the best because they've been there before, or where the ambulance takes them, essentially, right?
Mm-hmm.
So I would say that I don't, to be honest, I wouldn't foresee it suddenly having a change in where people end up. That being said, I mean, like, it's only going to get worse. We're all going to have more and more geriatric patients showing up. So, I mean, it sort of feels like everybody should have the certification. At the same time, it might be unrealistic, and maybe just the geriatric champion model that you're speaking of might fit some places better. So I think it's potentially specific in terms of how it looks like on paper, whether it's a certification or a champion. But certainly there's like a basic understanding of the care that geriatric population needs that should underpin every single hospital. So I wonder if part of semantics and part of it is we all agree that there should be a geriatric team ready to optimize these patients before they go home. And then a question of how is that impacting your your overall flow of the department, which is a whole other
Mhm.
assessment, I guess.
And that's a concern actually that that I've heard raised by no other than Dr. Troquet, who said that, is it even good to have the certification? Shouldn't you just have these services available just at baseline because it's better for patient care? Would the certification help your institution at all in a Canadian system? In the American system, I'm sure that there are financial benefits that are involved with getting this certification, but maybe it's just that we should just do good for the sake of doing good and not actually have the certification itself. Yeah. Anyway, thank you so much for your comments. We're over time now. But thanks. It was just a brainstorming session. Thanks so much for listening to that. And that calls it for rounds. We have, I believe it's recess hour for us at 1:15, I think. Yeah. So some of us will be at the Jewish, some of us will be on Zoom for that. So if there aren't any other questions, I think I'll call it, and I'll call this week's session to a close. So, all right. Thanks, everyone. Have a great week.
Thanks, Jake. Good luck at SIB.
Thank you.